Good afternoon, members. Welcome to the Assembly Committee on Commerce and Labor. Madam Secretary, please call the roll.
Assemblywoman Carlton.
Here.
Assemblywoman Considine.
Present.
Assemblywoman Dickman.
Here.
Assemblywoman Duran.
Here.
Assemblyman Flores.
Present.
Assemblyman Frierson.
Here.
Assemblywoman Hardy.
Here.
Assemblywoman Kasama.
Here.
Assemblywoman Martinez.
Here.
Assemblywoman Marzola.
Here.
Assemblyman O'Neill.
Here.
Assemblywoman Tolles. Chair Howdegi.
Here. Thank you. And Madam Secretary, please mark all members present. I see that Assemblywoman Tolles is here. Welcome to the audience tuning in over the internet. Before we start, I'd like to make some housekeeping announcements. Please remember all exhibits, testimony, and amendments must be submitted by noon on the business day prior to the committee meeting. Persons who wish to provide testimony or attend the meeting virtually must pre-register online at the legislature's website. The public is strongly encouraged to submit written testimony in advance of the meeting by emailing the Assembly Commerce and Labor. Zoom chat is reserved for committee business only. Members, please remember to keep your camera on at all times. This will ensure that we have a quorum unless you are stepping away for non-committee related business. Members and presenters, please remember to keep your microphone muted at all times unless you are answering a question. Then you can unmute yourself and then promptly mute yourself right after. Thank you, everyone. Let's go ahead and begin with our first agenda item. Today, our first agenda item is going to be a BDR introduction of a committee bill draft. BDR 10812 originated with the Committee of Commerce and Labor and was assigned to the Committee on Commerce and Labor for committee introduction. This measure addresses issues relating to the sales of residential property. Remember that a vote in favor of introducing a bill draft does not imply a commitment to support the measure later pursuant to Assembly Standing Rule 557, Section 7. All this action does is allow the BDR to become a bill and then go to the floor to be referred to a committee for possible hearings. I will entertain a motion to introduce BDR 10812.
So moved, Madam Chair.
I have a first by Vice Chair Carlton.
Second, Considine.
I have a second by Assembly Member Considine. Is there any discussion on the motion? Okay, seeing none. Madam Secretary, will you please call a roll call vote?
Assemblywoman Carlton.
Yes.
Assemblywoman Considine.
Yes.
Assemblywoman Dickman.
Yes.
Assemblywoman Duran.
Yes.
Assemblyman Flores.
Yes.
Assemblyman Frierson.
Yes.
Assemblywoman Hardy.
Yes.
Assemblywoman Kasama.
Yes.
Assemblywoman Martinez.
Yes.
Assemblywoman Marzola.
Yes.
Assemblyman O'Neill.
Yes.
Assemblywoman Tolles.
Yes.
Chair Howdegi.
Yes. Motion carries. Thank you, members. Okay, next item on our agenda is bill hearings. We have 4 bills on the agenda today, starting with Assembly Bill 180. I will now open the hearing on Assembly Bill 180, which revises provisions governing policies of insurance, which provide for the payment of expenses which are not covered by Medicare. I believe we have Assembly Member Alexis Hansen with us. Welcome to the committee. Member Hansen, when you're ready, please proceed.
Thank you so much, Chair Howdegi, for the opportunity, and good afternoon, and thank you, Committee of Commerce and Labor, for hearing this bill today. For the record, I'm Alexis Hansen, representing Assembly District 32. And it's in the course of the work that we do as legislators that we get the unique opportunity to be able to meet with our constituents and hear their needs and what we might be able to do here. And I'm going to let Millie Custer from Humboldt County tell you a little bit about her story, if that's okay, Chair, when I'm done with my opening remarks. But I'm here today, though, to present, as I've discussed with Millie and her concerns and found out there are many in the same situation in Nevada, that as I present Assembly Bill 180, which requires insurers offering insurance policies for the payment of expenses not covered by Medicare to offer at least one such policy to provide certain coverage to persons with disabilities under the age of 65. For Americans who become eligible for Medicare upon turning 65, enrollment in Medigap plans is guaranteed during a 6-month federally mandated enrollment period. During this time, all available Medigap plans are guaranteed issuance, regardless of a person's medical history. Medigap is a set of standardized plans that supplement what Medicare does not cover. These plans pay for items such as deductibles, co-pays, and co-insurance. States can create their own rules to to ensure that disabled Medicare beneficiaries under the age of 65 are able to enroll in supplemental insurance coverage, and the majority of states have done so. Nevada has not enacted a provision to ensure access to supplemental coverage for those who are disabled under 65, and there do not appear to be any plans with guaranteed issuance available for this population. I would like to walk through the bill real quick. I won't say that word simple because we know what that can do. But in the bill, in Section 1, there's just the 2 sections. In Section 1, the new language would be that the regulations must require each insurer offering such a policy to offer at least one such policy to provide coverage for persons with a disability who are less than 65 years of age and eligible for Medicare. There are 2 friendly amendments that are up on Nellis. And I also have here today, and Chair, at your pleasure, I have Millie Custer from Humboldt County from Winnemucca, my constituent, if she could have a moment to share her story and the statement of need that led me to bring this bill. And also for a resource for questions to be answered, since this certainly is not my expertise. I'm happy to have Heidi Sterner from the Nevada Association of Health Underwriters with us. Also Jason Casey, a Medicare senior benefits person from Reno. And then grateful to have the Department of Insurance, Mr. Childress and Ms. Ting here as well. So Chair, if it's okay, we can proceed however you'd like with with Millie Custer from Winnemucca and then those that are here as well.
Assemblymember Hanson, absolutely. Would you like to start with Ms. Custer?
Yes, if that's fine. Millie, if you would like to, please share your story. We'd appreciate it.
Good afternoon, everyone. My name is Millie Custer, for the record, from Winnemucca, Nevada. We've lived here 21 years. I've been partially paralyzed for 36 years from a brain aneurysm. I'm on Medicare, but due to the fact that I'm under 65, I'm unable to buy any supplemental insurance to help with the Medicare, so I'm stuck with the 20% all the time, and I've already done 2 knees. I need 2 hips, and so on and so on. I'm not looking for a handout, just an option. 1 in 6 states, we are 1 in 6 states, Nevada is, that does not offer any kind of a program. It is not, there's a lot of people in my vote, 1 in 6 people that are on Medicare are under 65 years old, and I would really like to have an option if we can see how to do something. And I think that it's needed for both parties, and it's a bipartisan thing, and we should be appreciative if you guys can help us out. Thank you.
Thank you, Ms. Custer, for being here with us today and for your testimony. Assemblymember Hanson, would you like to go to your next presenter, Ms. Sterner?
Thank you. Yes, Chair. Ms. Sterner has a PowerPoint, a very short one. I think she told me she could probably get through it in about 3 or 4 minutes. We thought it might be a good idea for us to have an overview of Medicare and what we're looking at as far as the supplements for those under 65 that are currently not offered and what we're trying to fix with this legislation. So I'll turn the time over, if that's okay, to Ms. Sterner.
Absolutely, Ms. Sterner. Thank you for being here with us today. When you're ready, please share your PowerPoint and you can proceed.
Are you seeing the PowerPoint?
Yes, we are.
Okay, so we're going to talk about Medicare supplements primarily, but to understand Medicare supplements, I think you need to get a little bit of a view of the parts of Medicare. So first off, Medicare is a federal program that's available to people who are 65 or older, and certain younger people with disabilities, and people who have end-stage renal disease, which is a permanent kidney failure requiring dialysis or transplant. There are 4 parts of Medicare. The 2 parts we're going to primarily focus on are Part A and Part B. Part A covers the inpatient hospitalization. Part B covers your outpatient care, such as doctor's visits, lab work, x-rays, and services related to outpatient. But it does not cover prescription drugs. That's going to be your Part D. We're not here to talk about Part D, but it's important to know that they would have the option of the Part D coverage. By virtue of having Part A and Part B, a person can purchase a Part D prescription drug plan. Persons in certain areas of Nevada have other options, and they do have a Medicare Advantage option, which kind of rolls all of that into one plan and gives you the Part A hospitalization, the Part B outpatient services, and often the Part D prescription drug plans in one plan. There are plenty of these options in a couple, 2 or 3 counties, but not many. In about 9 counties only have 2 plans, which may not appeal to everybody. So we're going to focus on Part A and Part B. Hospitalization Part A is a 0-cost premium if a person has worked for 40 quarters and paid into Medicare payroll taxes. There would be a premium if you have not met those 40 quarters for the Part A. Part B, everyone who enrolls in Part B will have a premium. The standard premium is $148.58 per year. That's the 2021 rate. And then you have your deductibles and coinsurance out of pocket. For Part A, a person who goes to the hospital would have a $1,484 per year coinsurance deductible, and then they're going to pay coinsurance. And you can see that I've broken it down here by days. So depending on how many days they're in the hospital. At the 151-day mark, they would be responsible for all costs. They also have varying copays by day for skilled nursing. There is no maximum out of pocket if you are in the hospital under Part A. Under Part B, which is the outpatient care for services such as doctor's visits, lab work, x-rays, you have a $203 per year deductible. And then once that's satisfied, then the member or the beneficiary would pay 20% of all costs that Medicare does not. They pay about 80% of covered expenses, and the member would pay 20%. Again, there is no maximum out of pocket. And this is where Medicare supplement plans come into play. They're also known as Medigap plans, and they help fill the gaps that original Medicare does not cover, and they are sold by private insurance companies. And that, again, would cover the deductibles, coinsurance, and copayments, for example. To purchase a Medicare supplement plan, you have to have original Medicare Parts A and B. It doesn't replace original Medicare. It just is a supplement to those 2 parts. You get them from private insurance companies, and there's a monthly premium. And this premium is in addition to any Part A or Part B premiums. They are guaranteed renewable as long as the premiums are paid and that the plan also stays active. Generally, they don't cover long-term care, vision, dental, hearing aids, eyeglasses, or private duty nursing. A person can enroll during, as Assemblywoman Hansen said, they can enroll in the first 6 months, and that's called your open enrollment period. And that typically begins when you turn age 65 and you enroll in Medicare Part A, you have Medicare Part A and B, and then you have that 6-month window. It's guarantee issue. You cannot be denied due to your health status during this period of time, and you can purchase the Medicare supplement, any policy sold in Nevada without that health status review. Outside of that open enrollment period, so right around those the time frame that you turn 65, currently, the option to purchase outside of that period is limited. If you are on a group health plan, for example, and you have Medicare Part B and you lose your group health plan, you would have, for example, 63 days to enroll into a Medicare supplement. Outside of that, you can apply for coverage. Your approval is not guaranteed. The coverage can be denied, or you can have a premium assessment attached due to your health history. For people that are under 65, they don't have that option currently, and federal law does not require that insurance companies sell these Medigap policies to people under age 65. So some states, so there's over 30 states that have the option for people under age 65 with disabilities to purchase a Medicare supplement plan. Nevada is not currently among that group of states. In 2019, and this data is from the Kaiser Foundation, which is, they get theirs from CMS, there were 561,986 Nevadans eligible for Medicare. 467,847 of those were due to their age. 63,717 were due to being disabled. Of that 561,000, currently 99,256 were enrolled in the Medicare Supplement Plan. 197,619 were enrolled in a Medicare Advantage plan. The remainder would either be the disabled who are not eligible to enroll in a Medicare Supplement plan, for example, and folks who are on an employer plan or a union plan or coverage through their spouse. And that is a brief overview of the Medicare supplements. And I'd be glad to take any questions that you have. And thank you for allowing us to present.
Thank you, Assemblymember Hanson, and thank you to your co-presenters as well. Assemblymember Hanson, we'll go to questions now. Committee members, any questions?
Yes, Madam Chair, I have a question.
Vice Chair Carlton.
Thank you. And this might be more for the insurance division, but since this is the underwriters, I guess I want to have a conversation about whenever you open up a new selection for insurance, we know insurance is a pool, and the more people in it, the more the dollars get divided. But also if you have folks that are more high cost, that sometimes it can have an effect on the premium. So by opening this up to folks under 65 who are disabled to be able to buy this, will it be mandated that each insurance company sell this, or we're just giving them the option? And has anyone done any analysis to see what this might do to that particular insurance product to see what the cost consequences might be?
You want me to take that? Hi, Heidi Sterner for the record, from the Nevada Association of Health Underwriters, through the chair to the vice chair. I am going to kick that over to the insurance commissioner office, just simply because it's dealing with rates, and that's the entity that would deal with any rating factors with regards to the insurance companies and their risk pools.
And on the other part of the question, this will just be an option for them to sell, and we're not going to mandate that it be sold?
The way the bill reads is that each insurance company that offers Medicare supplement plans would have to also offer a plan to folks under age 65 with a disability.
So it's an insurance mandate?
It is a mandate for them to offer a coverage, yes.
Okay. All right. Thank you.
King, I believe you're here on behalf of the Nevada Department of Insurance. Did you want to address Vice Chair Carlton's first part of the question?
Yeah, I'd love to. My name is Nicole Ting from the Nevada Division of Insurance. Thank you very much for your question, Vice Chair. So I have with me Jack Childress, who is our Medicare supplement policy specialist, and he has done some research. He's asked some other states regarding possible rate increases. So if it's okay with you, Madam Chair, if we could ask Jack Childress to testify.
Yes, Mr. Childress, are you with us?
Yes, I'm here. Can you hear me?
Yes, sir, we can hear you.
Hey, Chair, through you to the Vice Chair, in answer to your questions, the way the states treat this is different among the states. I surveyed the states to be prepared to answer your questions related to the rating. And some states will put the members under 65 in a separate pool or risk category so they can rate them up higher. Some states require them to have the same rates as the people who are age 65. Some allow them to rate them at a certain factor, such as 3 to 5 times age 65. Some states may cap it at the age 99 rate. So it just varies depending on the state.
Thank you, Madam Chair. So that if I may have a follow-up, do we have any indication how the state of Nevada will look at this and where they might go as far as the rating and rates on this?
Vice Chair, through the chair. Right now in our regulations through NAC 687B, the only rating requirements we have currently are the loss ratio requirements, whether the policy is individual or group basis. We don't tell the actuaries how to develop their rates or how they're going to pool their experience. So at this time, it would be up to them.
So just to clarify, because we're doing insurance speak here and not everybody who's listening might not actually know this language of insurance speak, that the individual companies that'll be mandated to provide this will do an actuarial look at it and decide where they think their rates might be. There won't be any guidance from the state on whether it should be a separate risk pool or not. That'll be left up to the individual companies.
Vice Chair, to you through the chair. At this point, I'd probably have to talk to the commissioner to find out for sure, but at least the way our regs are currently written, that would be the case.
And thank you very much, Madam Chair. And thank you, Mr. Childress. Insurance, it can be very confusing to folks, and I always want to make sure when we make a record that it can be understood in plain English for folks. So thank you very much, Madam Chair.
Thank you, Vice Chair, for your questions. Members, any other questions? I'm looking for a show of hands, and I don't see any. Okay, at this time, we will go ahead and go into testimony in support of Assembly Bill 180. Broadcasting, can we please check the telephone line for any people wishing to testify in the support position?
Yes, Chair. To testify in support on AB 180, please press *9 now to take your place in the queue. Caller with the last 3 digits of 710, please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Excuse me, Madam Chair. My name is Louis Trout. I'm a resident of Humboldt County. I'm also a board member on the Humboldt County Hospital District, although I'm speaking as an individual today, not as a representative of the district. The current situation that's been described is an inequity that needs to be corrected. During the sacred time of the year, leading up to Passover and Easter, as President Biden has made clear, we all have a social responsibility to assist those in need when we can. AB 180 provides such an opportunity to help disabled people with a helping hand. Thank you, Madam Chair.
For your testimony, sir. Broadcasting, next caller, please.
To testify in support on AB 180, please press *9 now to take your place in the queue. Chair, there are no more callers in support at this time.
Thank you, Broadcasting. Next, we will hear testimony in opposition of Assembly Bill 180. Can we check the telephone lines for people wishing to testify in opposition?
Yes, Chair, to testify in opposition on AB 180, please press *9 now to take your place in the queue. Chair, there are no callers in opposition at this time.
Thank you, Broadcasting. Can we check to see if there is anyone on the line wishing to testify in the neutral position?
To testify in neutral on AB 180, please press *9 now to take your place in the queue. Chair, there are no callers in neutral at this time.
Okay, thank you. Assemblymember Hanson, would you like to give any closing remarks?
Just real quick, a thank you to all of you for your time. Thank you to those who helped me with understanding this and presenting this. And just a reminder that in the amendment, we are asking for the Medicare Guarantee Issue Plan so that these can be affordable for those that are disabled under 65 to be able to get this Medigap insurance that will help them out. So again, thank you for your time, and available for questions offline if as this bill progresses. So thank you.
Thank you, Assemblymember Hanson. Okay. At this time, I would like to turn the virtual gavel over to my Vice Chair Carlton to go to the next agenda item. Vice Chair Carlton, when you're ready to take the gavel, I will hand the virtual gavel over to you.
Okay, I think we are good. Thank you very much, Madam Chair. I'm happy to help out. So with that, committee, we'll go ahead and open up the hearing on Assembly Bill number 250 being presented by Chairwoman Houdegy. Ms. Houdegy, if you would like to proceed.
Thank you, Vice Chair Carlton and members of the committee. For the record, I'm Assemblywoman Sandra Houdegy, proudly representing Assembly District 41, and I'm here with you today to present Assembly Bill 250, which establishes the birthday rule for persons who are currently enrolled in a Medigap plan. The genesis for Assembly Bill 250 was from my constituent, Rick Bronstein, who you will hear from today. Over coffee, Mr. Bronstein explained that Nevada has never had an open enrollment for Medicare supplement plans. As you know, the Medicare program, which is administered by the Centers for Medicare and Medicaid Services, also known as CMS, is the federal health insurance program under which qualified individuals receive health care. Medicare does not cover all medical expenses or services, and it also does not pay 100% of certain covered services. Although Medicare pays for a certain preventative services and covers most medically necessary services, the percentage of out-of-pocket healthcare expenses for Medicare beneficiaries can be sizable and typically increases with age. Medicare supplement insurance, also known as a Medigap policy, is a distinct type of insurance policy which is sold by private companies to fill the gaps in original Medicare plan coverages. Medigap policies are guaranteed issuance at certain times for eligible beneficiaries as specified by state and federal law. For example, at the point where an individual first becomes eligible for Medicare, there is an open enrollment period when Medigap coverage can be purchased without medical underwriting. Medigap policies are guaranteed renewable as long as the premium is paid and, generally speaking, cannot be canceled because of a person's health condition or for any reason other than non-payment of premium. Insurers can, at their discretion, increase the premiums for Medigap coverage. However, unless eligible for open enrollment or guaranteed issuance, Medicare beneficiaries wishing to purchase Medigap coverage or change plans are subject to medical underwriting and can be denied coverage based on their health status or claims experience. What is so great about the birthday rule? It provides an opportunity to enroll in a plan from a company that may offer better coverage to suit the needs of the consumer without medical underwriting. This means that just like when a person first signs up for a supplemental insurance policy during the open enrollment period, an insurance carrier is prohibited from denying coverage based on pre-existing health issues. Assembly Bill 250 requires an insurer, nonprofit hospital, and medical or dental service corporations that issue an insurance policy that provides for the payment of expenses not covered by Medicare to offer an annual enrollment period to change to a plan of equal or lesser benefit without being subject to medical underwriting. The open enrollment period would begin on the first day of the birthday month of an enrollee and continue for 60 days. This bill also provides that 30 to 60 days before the beginning of the open enrollment period, an insurer must notify enrollees of the date that the open enrollment period begins and ends, any rights of the insured to change to a different plan, and any modifications of the current benefits. Assembly Bill 250 offers Nevadans who have Medigap policies to annually review the price and coverage of their policies. I would like to be clear, though, this measure is not a free pass for people to obtain Medigap policies who do not currently have them. Instead, it allows enrollees to consider if other policies are available that better suit their needs. Vice Chair, I would now like to turn it over to Christopher Carruthers with the Health Underwriters Association to give brief remarks, followed by my constituent, Mr. Bronstein, to give brief remarks.
Thank you very much. And if we could have the next presenter, please.
Hello. Can you hear me fine?
We can hear you. Welcome to
Great.
the committee.
Great. Thank you, Madam Chair and Vice Chair and committee. First of all, my name is Chris Carruthers. I am a president-elect of the Nevada Association of Health Underwriters. I'm also been in the brokerage business and selling insurance for 30 years here in Southern Nevada. Our organization for the health underwriters, we are a professional organization for our health insurance industry. AB 250, as we call it, the birthday rule, is an important bill that would help many Nevadans who are insured by Medicare with a Medicare Supplement, also known as a Medigap plan. Currently, anyone who has medical insurance has an open enrollment once a year, regardless of their health status. They can move, change, switch to another medical plan. This would include Nevada Health Link, Medicaid, small and large employers, Medicare Advantage plans, except those who have Medicare Supplement plans. Everyone has an open enrollment to move to a new plan regardless of health status. Again, regardless of health status, except those who have a Medicare Supplement plan. This bill would allow for those who have Medicare Supplement plans can switch to another Medicare Supplemental plan once a year around their birth month, as you just heard, to another insurance company or with the current insurance company at new lower rates that they're offering, with no reduction in benefits regardless of health status. As insurance producers, we've had our clients receive rate increases every year for their supplemental plan. The clients contact us to help us change plans, yet we can't help them change a plan because due to health conditions, and they don't have to be serious health conditions. It could just be something that they're just trying to manage that is very manageable, if you will. And we just can't help them. Our association has been discussing the birthday rule for some time now. And we've discussed with the Department of Insurance, carriers. We've had our meetings to discuss the impact to our clients. And the passing this bill, we are in support of this, passing this bill, AB 250. And we've also submitted our recommendations for your consideration. One of the thing I thought about during the other speakers, I realized that we didn't mention the reason why people want to choose a Medicare Supplement plan is choice. You can pretty much go to any doctor, any hospital in America. That means a lot when you deal with people with some serious conditions and the doctor that they trust is not contracted with one of the local HMOs or PPOs or these rural areas in Nevada. They need choice to have access to doctors, and that's what Medicare Supplement plans do. And so we have limited these people financially because the rates keep going up, yet they're on the edge of how do I pay for my insurance and take care of myself and still seek the care I need from my doctors that I trust. So we're in full support of this AB 250. It's long overdue, and I'm here and I'm happy to answer any of your questions. Thank you.
Thank you, Mr. Carruthers. Vice Chair, if we could go next to my constituent, Mr. Bronstein.
Please, Mr. Bronstein, welcome to the committee.
Thank you very much, Vice Chair, and of course, the Chair, to letting me speak about this. And I come from California, as probably 90% of us do. And in California, the birthday rule has been around for a while. It currently says you can apply to change your plan without underwriting. You can't go up in benefit 30 days before your birthday with an effective date between your birthday, no earlier than your birthday, and you could apply up to 60 days thereafter. It gives everybody that has a Medicare Supplement plan, including those under 65, the ability to not have to overpay for their policy. I don't know if you want me to get into this. I'll go over it very quickly. I did some quick rate comparison because I'm sure the concern, or at least a question by somebody, would be what happens to rates? If now we're going to let people move all the time, what's going to happen to their rates? So I did a comparison with using a zip code in Henderson and a zip code in San Francisco. Population in Frisco is about 3.3 million, and Clark County is 2 million and change. So it's kind of similar. And I looking at a 70-year-old using United Healthcare, not because they're the lowest price, but they have the preponderance of business in both states. For a 70-year-old, the rate is $4 less in San Francisco. For a 75-year-old, it's $11 less. For an 80-year-old, it's $40 less. Same company, same benefits. And I use Plan F, which I'm not a big fan of, but that's the one that covers 100% of everything. Even in Nevada, one can go, a 70-year-old could save $40, a 75-year-old could save $60, an 80-year-old could save about $70 a month just switching from one company to another. And that's not even doing a rate comparison. It's the same exact plan. If they wish to, I'll use the word downgrade and have the same plan but pay the $203 deductible, which means going from Plan F to Plan G. That 70-year-old that right now is paying $200, assuming they're paying $200, can go down to $133 a month. The bottom line is, even after paying the deductible, at virtually every age, regardless of health, a person could save $900 a year. And I've used female rates. California has no gender rating, so I had to keep I wanted to keep it equal. If we look at rates for men, it would probably be even more. And in California, I have many, many clients that could otherwise not qualify, but I was able to get them a much lower price because of the birthday rule. It's not fair that somebody buys a policy from, and I won't even mention the company, from one company that keeps changing their pool every couple years, starts a new company, closes the old company. Healthy people can leave. People that are not healthy have to stay at ever increasing rates with no options. I have a client who is 76 years old. He's got an illness that would keep him from getting insurance, but he's never had treatment for over 20 years. It's not going to happen to him. If he was in California, I could have saved him $1,100. Same benefits, no difference. Beneficiaries in Clark and Washoe and a few other counties at least have the option to go into Medicare Advantage despite the fact that they have a limited network and may or may not get the treatment that they need. But what about rural areas? These people really have no options. If they buy a Medicare supplement when they turn 65 and it goes up in price to the unaffordable stage, what are their options? If they're not healthy, they can't save any money. If they drop their expensive supplement, they may be out thousands and thousands of dollars if they need care. Anyway, this is why I got together with the chair, and it's been almost 2 years now, I think, to discuss this, and immediately she saw the need, and that's terrific. What I did not do, and then I'll say goodbye, I didn't introduce myself. Rick Bronstein, I've been in Nevada now for 5 years from California. I've been licensed since the beginning of time, 1977, and I've been in Medicare since 1993. That's my presentation. I'm here for any questions.
Thank you, Mr. Brown. And Vice Chair, I did want to let the committee know that I submitted an amendment that's available on NALIS. It was my amendment to clarify that the bill I'm introducing is only to apply to Medicare supplement plans. So I added the supplement plans to the language so that it was clear that the bill is only for Medicare supplement plans. And I don't have an amendment yet, but I am working on an amendment with some of the insurance groups to address the notification. They did say that having it be a mandate to require them to send out annual notifications prior to the open enrollment period might increase costs. So I'm working with them to see which notifications they send out annually now that we can add this on to, so that there's no further costs bared, and translation increased costs to the insureds. With that, Madam Vice Chair, we are open for questions, and I do have Mr. Carruthers here to help answer questions, as well as the Division of Insurance.
Okay, thank you very much, Chair Howdigi. Good presentations, made things very clear. I think it would have been great if my husband and I could have talked to Mr. Brownstein before we had to make this decision a couple of years ago on what to buy. It's a very tough decision the first time you sit down and look at it, and then knowing in the back of your mind that once you've made that decision, you're kind of stuck with it for a while. So knowing that this just gives the constituent an option, and that's what I'm hearing, and I just want to make sure this just gives the constituent an option to basically do what we preach to folks, is shop your insurance and try to get the best rate that you can get. So is that my understanding of the bill?
Yes, and I will answer that and allow either Mr. Bronstein or Mr. Carruthers to come in after. But yes, and it's important to know, Ms. Carlson, it provides them now an option to move to an equal or lesser insurance plan. And I think it's important that we note that. Mr. Carruthers or Mr. Bronstein, I'm not sure if any of you have anything else to add to that.
Well, I'm an insurance agent, so I'm always willing to talk. Yes, that's exactly what happens in California. If you are on Plan F, which covers 100% of everything, all your out-of-pocket costs, and you want to downgrade, if you will, downgrade is in quotes, you can save even more money, and you just do the math. It gives people the option to do what they think is best for them, and it gives insurance agents the opportunity to help more people. This is not a partisan issue at all. It helps the consumers in Nevada. It does not harm insurance companies based upon California rates. I really hope that it passes. It's so good for consumers.
Thank you very much, Mr. Bronstein, and it was nice to meet your puppy behind you also. So thank you very much. We always enjoy a good pet sighting in a hearing. So that's one of the benefits of Zoom meetings. So committee members, is there anyone that has a question for the chair or for Mr. Bronstein or Mr. Carruthers as far as the particulars of the bill? Ms. Kasama, did you have a question?
Yes, thank you, Vice Chair Carlton. Thank you so much for the presentation and the overview. My question, just to clarify again, you said that the bill only applies to Medicare supplemental bills. It's also the ability to move to an equal or lesser plan, to downgrade in quotes. My question is, if you move down or go to a downgrade, could you later move up again, or once you've made that decision, you remain at that level?
Assemblywoman Sandra Howdigi, for the record. Vice Chair, I am going to defer to the experts in this field to help answer the question. Mr. Carruthers or Mr. Bronstein? I see.
I'd like to address this, Madam Chair.
Yes, Mr. Carruthers.
First of all, we didn't cover one thing that I wanted to make sure was clear, is that the federal government standardized the supplemental plans, A through N. It's another alphabet. And so when a consumer wants to switch plans from an F to an F or a G or a G, being like kind, they're exactly the same plan, essentially. There is no difference in plans. It's just different rates, different company. And so the idea is to be able to allow people to move to a like kind plan equal to or less than. And the reason why we left it generic in nature and our thought process is that what if the federal government decides to eliminate any of these alphabet plans and add new alphabet plans? So the idea is allow people to be able to move sideways to something equal to or less than is the idea. But to answer your question specifically, no, it's not meant to upgrade. That's something that it's been discouraged in our industry for years because it's really that's really unfair to the insurers on that level. So we need people to be able to pay to play, if you will, and then everyone benefits by it. But just to jump back and forth when you feel like it, well, I'm healthy now, I'm going to buy down, and then I'm sick, I want to buy up. It's really not a fair thing to do.
That makes sense. Thank you. And Chair and Vice Chair, may I have one other question?
Go ahead, Ms. Kasama.
So then also, just for me to understand with clarification to the birthday rule, because we're also changing that. So right now, there's just an open enrollment, let's say November 1st, and that's what it is for everybody. And now we're going to make it so you can do it on or around your birthday month. Is that correct?
So
May I take this one?
Sure.
Please proceed.
Thank you. The birthday rule is, when you're talking about the November rule, that does not apply to Medicare supplements. There's an open enrollment for Medicare Advantage, there's an open enrollment for the prescription drug plan, and of course, ACA has an open enrollment. This is specific to Medicare supplement, Medigap plans. They do not have any open enrollment period other than when you first get your Medicare Part A and B. That you could be 65, you could be 70. Hopefully you can be disabled. I'd love to see 180 pass as well. But it has nothing to do with anything other than people who have chosen a Medigap plan. For example, I'm unfortunately or fortunately over 65. Over 65. When I turned 65, I bought from a particular company. Well, their rates went up in the last 2 years. And I was able, because my health is okay, to switch carriers and save $30 a month, same plan. What if I couldn't? What if I had carpal tunnel syndrome? What if I'm taking a painkiller just for my back?
So what is the current time frame to, how is it currently done to get Medigap?
I'm sorry, say that again?
What is the current time, how does it currently work if you want to get the supplemental insurance?
Okay, let's talk. That's pretty simple. I hate to use that term. And Chair, is it open?
Howdegi, did you want to answer that question, Ms. Howdegi?
Yeah, because if I could, Assemblywoman Sandra Howdegi and Member Kasama, that presentation that Ms. Sterner had, I loved it because it taught me a lot, but it kind of showed you how the Medicare supplement worked, how you can only enroll in a Medigap plan when you first become eligible for Medicare insurance without health underwriting. And the reason the birthday rule is so important is because without the birthday rule, you don't have another open enrollment in period where you can change policies to an equal or lesser policy without health underwriting. And so that's why. So right now we currently don't have an open enrollment period for a supplemental plan. So if you did want to change, you would then be subject to health underwriting. So if you did now have a pre-existing condition, your supplemental plan would be more expensive.
Okay. I'm just thinking that right now, let's just use November 1st. Everybody signs up for November 1st. And if you miss it, you have to wait for November 1st again versus your birthday month.
And Ms. Kasama, my understanding, and Ms. Howdegi, please go ahead.
Assemblywoman Sandra Howdegi for the record. Thank you, Vice Chair. And Assemblymember Kasama, so right now there is no November 1st open enrollment period for supplemental insurance plans. So they wouldn't have to wait. So there is no second open enrollment period. So if they wanted to, they would have to go through a health underwriting process. So that November 1st open enrollment period doesn't apply to supplemental plans.
Okay, thank you.
I apologize. I believe that Assemblywoman Hardy had a question.
Yes, thank you, Vice Chair. And I think this is a great presentation because unless you really get in and work in Medicare, it can be very confusing. And I've learned a lot in the last few years navigating this, trying to help my own parents and understand when they can enroll and what all the different plans are and what they need. So I think that was a really good intro. So I just have two questions. In section 1, sub 1 there, you put, we have remaining open for at least 60 days. I was just curious how you arrived at those 60 as opposed to 30 or 90. That's my first question.
Thank you for the question, Assemblymember Hardy. This is Assemblywoman Sandra Howdige for the record, and I just modeled it after current laws in other states that allow for the 60-day period.
Okay. And then my second question is just kind of thinking of the logistics of it, because as we've established, there's certain enrollment periods of when folks are able to enroll in different Medicare plans. So with this, essentially people would be enrolling every day or, throughout the year. So this might be best for the Medicare folks, but how do you see that affecting the ability to take care of the other members? I mean, do you see it's going to, just logistically, how do you see that working?
Assemblymember Sandra Howdige for the record. So I think your question, Ms. Hardy, directed to insurance brokers? Or are you actually, is that question for the insurance companies?
Well, I guess maybe just how this is gonna, if you're having an enrollment date, every month, basically for an individual's birthday, they're able to enroll. Whoever is handling the enrollment, is that the individual insurance company or is it Medicare? I'm just trying to figure out how logistically it's going to work. Is it going to be a large increase in caseload? Do they foresee that? Does that make more sense?
That sounds like a question that would be directed to the health insurance groups like United Health Group or Anthem. And I don't believe we have anyone here from those groups to help answer that question, Ms. Hardy, but I will reach out to them and get an answer for you and for the committee as well.
Okay, thank you.
Okay, thank you, Chair. And so with that, I believe Ms. Dickman had a question.
Thank you, Vice Chair Carlton. This is pretty complicated, isn't it? But my question, and maybe has nothing to do with this bill, but can you switch? You said you can't switch levels, correct? Right, currently? Can you switch between companies and maybe get a better rate? Just kind of curious.
Thank you, Assemblymember Dickman. For the record, Assemblywoman Sandra Howdige. I am going to turn it over to one of the experts I have with me, Mr. Bronstein or Mr. Carruthers. Would one of you like to take that question from Assemblymember Dickman? Mr. Bronstein?
Thank you. I would love to. Using the birthday rule, you can switch within a company. You can switch to another company. Whatever works best for you, you can do what you'd like. It just gives you the opportunity to change your plan.
But currently, the way things are now, can you switch companies yet not switch levels? Or?
If you are healthy enough to pass underwriting,
okay,
you can do anything in every month, anytime you want. The birthday rule just gives you a once-a-year open enrollment. The logistics there's not an issue. I can submit an application for Medicare Supplement for 70-year-old underwritten, or if it's in California, I can submit it on their birthday rule, not underwritten. It's the same application, and it's not harder on anybody. In fact, it's easier on the companies.
Great. Thank you so much. That really helped.
Thank you.
So with that, committee members, is there anyone else wishing to ask a question at this time? I'm not seeing anyone asking to be recognized at the moment. So with that, Ms. Howdige, I believe we can go ahead and go to those in support of the bills. So Do we have anyone on video in support, or we're going straight to the phone lines for support, if I understood correctly?
Yes. Yes, Chair Carlton, Vice Chair Carlton, I didn't have anyone lined up to testify on video.
Okay, thank you. So broadcast services, if we could go to those in support that are on the phone line, please.
To testify in support of AB 250, please press star 9 now to take your place in the queue. Again, to testify in support of AB 250, please press star 9 now to take your place in the queue. Chair, there are no callers in support at this time.
Thank you very much, broadcast services. If we could go to give that opportunity to those that may be in opposition on the phone lines, please.
Testify in opposition on AB 250, please press star 9 now to take your place in the queue. Again, to testify in opposition on AB 250, please press star 9 now to take your place in the queue. Chair, there are no callers in opposition at this time.
Thank you very much, broadcast services. We'll go to the neutral position then, please, on the phone lines.
Yes, Chair. To testify in neutral on AB 250, please press star 9 now to take your place in the queue. Again, to testify in neutral, please press star 9 now to take your place in the queue. Caller with the last 3 digits of 523, please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Thank you, Madam Chair and members of the committee. My name is Tom Clark. I'm here on behalf of the Nevada Association of Health Plans. First, to spell my name, it's Tomclark. First, I'd like to thank Chair Hadegui for bringing the bill and for the extensive work that she's done with us leading up to the hearing. Excuse me. And as you've heard, the birthday rule in other states allows individuals with a Medicare supplement plan to move to an equal or lesser plan, policies that we would support here in Nevada. As the chair acknowledged, we are working with our own amendment that will change the language in AB 250 from open enrollment to guaranteed issue rights kind of a situation, simply because the term open enrollment can cause quite a bit of confusion. We look forward to continuing to work with her on the language to address those concerns. And I will also reach out to Assemblywoman Hardy to answer some of her questions as well. Thank you, Madam Chair.
And thank you very much, Mr. Clark, for offering to answer those questions. We appreciate it. And if you would make sure to share that information with Ms. Hadegui so that all the committee members can have the opportunity to hear that answer, we would greatly appreciate it. So with that, broadcast services, do we have anyone else on the phone in neutral?
Chair, there are no more callers in neutral at this time.
Thank you very much. Ms. Hadegui, do you have any closing comments, please?
Thank you, Vice Chair Carlton. I just want to thank you and thank the committee members for hearing Assembly Bill 250. I would like to thank my constituent, Mr. Bronstein, he is correct. He first brought this issue to my attention almost 2 years ago over coffee, and I'm happy that he did because I'm proud to be a part of it and proud to carry this bill. I will make sure that we do get that question that Assemblymember Hardy had answered and shared with the whole committee. With that, thank you, Vice Chair Carlton.
Oh, thank you very much. With that, I will hand the virtual gavel back to the chair so that she can continue with the meeting and we can move on to the next bill. Happy to be your backup, Madam Chair.
Thank you, Vice Chair Carlton. Okay, members, we are going to take our next agenda item out of order. Our presenter for Assembly Bill 274 is caught up in another committee. So if we have our presenters for Assembly Bill 278 here, I'd like to go to that agenda item next. Assemblymember Duran, are your presenters here and would you be willing to go next?
I believe, I believe they were here a while ago. Yes, they are here.
Okay, perfect. Thank you so much, Assemblymember Duran. Sorry that I put you on the spot like that, and thank you for presenting your bill out of order. Assembly members, I will now open the hearing on Assembly Bill 278, which provides for the collection of certain information from physicians. We have our own Assemblymember B. Duran here to present the bill. Assemblywoman Duran, when you're ready, the floor is yours.
Okay, thank you. Good afternoon, Chair Howdegee and members of the committee. I am B. Duran, representing Assembly District 11 in Clark County. Thank you for your time today and for allowing me to present Assembly Bill 278, which requires a physician to complete a data request when renewing his or her license or registration. Today, I will provide background information, and Bobette Bond, Director of Public Policy at the Culinary Health Fund, and Maya Holmes, Healthcare Research Manager for the Culinary Health Fund / Unite Here, will provide details of the bill. Nationally, private equity firms are making a splash in healthcare. According to the Journal of the American Medical Association, acquisitions of physician practices by private equity firms have more than doubled from 2013 to 2016. However, the extent that the firms have infiltrated the industry has been difficult to quantify due to the non-disclosure agreements and other business practices. Private equity firms have been at the center of the surprise billing controversy that has taken the industry by storm. Congress is looking at the billing practices of physician groups that are owned by private equity firms, which may be behind the bulk of the balance billing, a practice which leads to unexpected, excessive medical bills for patients. Research is limited to the impact of the physician practices being acquired by private equity firms. There may be unintended consequences in other parts of healthcare, including on how delivery and quality of care will be affected in the long term. Another national trend is the consolidation when the local hospitals merge into massive health systems. It can significantly affect the practices of private physicians. According to the Loan Institute, from 2012 to 2016, the number of hospital-acquired physician practices increased from 35,700 to more than 80,000. By 2018, 44% of physicians were employed by hospitals or health systems, nearly doubled in the rate in 2012. Hospitals often claim consolidation helps improve care coordination and efficiency, but research studies have not shown consolidation improves patient outcome. Rather, consolidations may lead to higher prices for healthcare services because larger health systems command greater market share. According to the researchers at Healthcare Pricing Project, prices at hospitals that have a regional monopoly are 12% higher overall compared to hospitals that have 4 to more rivals. Nevada, like other states, is limited in ensuring these changes in the marketplace do not have a negative impact on patients and public and private payers. Briefly, 278 requires a physician to complete a request for certain data when renewing his or her license with the Board of Medical Examiners and the State Board of Osteopathic Medicine. The Department of Health and Human Services must develop the data request. The confidential information obtained by the licensed board must be sent to the department, which will collect and maintain it. Assembly Bill 278 is an initial effort to monitor healthcare consolidation and protect competition between healthcare facilities. We will continue to see consolidation across all facets of the healthcare system. It is not a question of whether consolidation is good, but the question which must be answered is how investment in consolidation will provide patients access to cost-effective, high-quality care in Nevada. And with that, Madam Chair, Ms. Bond and Ms. Holmes will discuss the details of the measure, and at the conclusion of their remarks, we would be happy to answer any questions regarding the bill.
Thank you, Assemblymember Duran. Ms. Bond? Are you with us?
Do you mind if Maya Holmes goes before me? She's got prepared remarks.
Absolutely. Ms. Holmes, when you're ready, the floor is yours.
Great. Thank you, Chairwoman Hargey. For the record, my name is Maya Holmes, and I am the Healthcare Research Manager for the Culinary Health. I'm here today with Babette Bond, as you know, the Senior Health Policy Director, also at. And we want to thank Assemblywoman Duran for bringing this important bill forward. We would also like to thank Chairwoman Hargey, Vice Carlton, and the committee members for their consideration of this important legislation. As you may be aware, Nevada has one of the largest traditions in the United States. We are the 45th in the nation in providers per capita, 50th for primary care. Nevada ranks 48th in the country for clinical care, 44th access to care, 42nd to adults avoiding care because. Lastly, Nevada ranks 47th in the nation for quality. Yet little is known about the specific market forces that may impact the physician shortage, access, affordability, and quality, including basic information like who owns or has bought any given physician state.
Ms. Holmes, so we have to get closer to the microphone.
Oh, I'm sorry. Is this better?
Yeah, we have you cutting in and out a little bit, so I think if you get closer to the microphone, it'll help with the audio and hearing your testimony.
Okay, sorry. Is this better?
Yes, that's much better. Thank you so much.
Do I need to go back or should I just continue?
I think you're good if you continue.
Okay, great. Thank you. So ownership of physician practices has changed dramatically over the last decade. American Medical Association announced in 2019 that more physicians were employed than independent for the first time. The Physicians Advocacy Institute in Avalere Health conducted a study that found 44% of physicians were employed by hospitals in 2018, from 25% in July 2012. Yet this is often national data based on periodic surveys. We do not have a comprehensive picture for our state, much less one that is current or really demonstrates trends in Nevada's healthcare. Some reports indicate hospitals now employ physicians who had been in private practice because of increasing overhead, reimbursement issues, and the administrative responsibilities of the. However, independent doctors have lower burnout rates. The employment status of doctors may also affect patient access. Employed physicians typically see fewer patients in a day on average than private practice. Physician employment status can also affect affordability. Hospital acquisitions of physicians increased physician prices on average 14%, 33.5% for cardiologists, and 12 to 20% for orthopedists, according to the research study. Other studies have shown that private equity ownership of physician practices also leads to higher prices. Physician ownership can affect referral patterns. A Stanford study showed that physicians increased referrals to the hospitals that employed them, and that patients were more likely to be treated in a high-cost, low-quality hospital where their admitted physician's practice is owned by. This bill would really allow policymakers, providers, patients, and payers to understand critical trends in Nevada's healthcare market and their impacts on physician volume, density, and practice. Specifically, the bill proposes to add existing licensing, renewal, and biennial registration requirements for physicians, a field that specifies whether the physician is employed or independent, and if employed, where the physician practices and which entity owns the practice. Specifically, the following would be included in licensing. Whether the physician is employed as part of a hospital or health system owned practice, independent. If employed by a hospital or health system, the hospital or health system name. If employed by another entity, the ownership legal entity name and fictitious firm name. And whether the physician is in solo or a single location small practice or multi-specialty, multi-location. Applicants for renewal of a license by the Board of Medical Examiners and the State Board of Osteopathic Medicine would provide the information prescribed by the Department of Health and Human Services pursuant to the bill's provision. The boards are to include these data requests in applications for license renewal and biennial registration and transmit the data to the government. Any reporting on the data would be aggregated to protect provider private requests and not reveal the identity of the person. However, as Assemblywoman Duran noted in her opening remarks, it really is critical that policymakers, the public, and private players and patients understand the roles of entities like private equity and other major players that are consolidating the physician market to understand consolidation's impact on accessibility and affordability. For example, we know in Nevada that the NICU and emergency room physician groups are now owned by large private equity groups in a number of cases. And we would like to see how that impacts price access and contracting status over time. But without any reporting of who owns these and other practices in Nevada, such trends will be impossible. The intent of the legislation is really to simply add an additional data request to already required licensing and registration reporting steps. The information would obviously be known to the physician, so we don't believe it's an administrative burden. The information requested is also already in the public domain for each provider. That is, if you wanted to go and research websites, public filings, you could find the information, but it's really not available, currently collected or aggregated in a way that is accessible, meaningful, and useful for policymakers. So now I'd like to turn it over to Babette Bond. Thank you.
Thank you, Madam Chair, and thank you, Maya, and thank you, members for the committee. My name is Babette Bond. Can you hear me okay now? Am I okay?
Yes, Ms. Bond, we can hear you.
Thank you. You spell it Bobbette, and my last name is Bond, like James Bond, Bond. And I'm the Policy Director for the Culinary Health Fund. I really appreciate Assemblywoman Duran bringing the bill today. This is the result of a couple of years of us trying to understand what's going on in the healthcare market in Nevada and ways that we can get more disclosure and more transparency into the system in Nevada. Just one more data point to add to the data that Assemblywoman Duran and Maya Holmes just gave you that's been recently added to the Journal of American Medical Association. The pandemic has led to even more consolidation than was already occurring at a really high level. There's been more, in just the last half of 2020, there were more than 150 private equity deals nationally that were closed, covering a range of healthcare sectors. And 2/3 of them were about providers and their healthcare services. So Las Vegas has been dramatically impacted by this, but unless you contract for healthcare all day long, it's hard to see it happening. And we don't have either the technology or the data to start monitoring this. And it's a huge cost driver for Medicaid, for PEBS, for our private health plans, and for the county health plans. So the coalition is supporting it as well, which you'll hear briefly later, our Health Services Coalition. These large companies can really take over like a whole industry sector. Like as Maya said, they're in the ER departments of several of our hospitals, and what we know there's a change market.
Ms. Bond, we have you cutting out. If you could.
Yeah. Is this better?
Yeah, there you go. Sorry, it looks like the connection was just locked.
Yeah, it just locked. So this bill would impact two boards, and I'm sure you'll be hearing about them, the Nevada State Board of Medical Examiners and the Nevada State Board of Osteopathic Medicine. But what we wanted to do is just create a really quick and efficient funnel to provide this information from the physicians into the boards, and then have the boards send that to the HHS so that we would be able to see these patterns over time and the trends that they're creating without a lot of new burden and a lot of new fiscal notes. An efficient way to do it. And that's really all I wanted to add, and I'm happy to ask questions since we are involved in the contracting to create a need to understand the system better. And thanks for your time.
Thank you, Ms. Bond, and thank you, Assemblymember Duran. And and Ms. Holmes for your presentation. Ms. Bond and Ms. Holmes, if you wouldn't mind emailing, if you guys had prepared remarks, would you mind emailing those to our committee manager so she could post them and share them with the committee members? There were periods where we lost connection a little bit, and I want to make sure that the members have all of the information that you were sharing with us today.
Yes.
Okay, and Assembly members, we are now going to the question portion of the bill hearing. Do I have any questions?
Yes, Madam Chair, I do, but I'll be happy to defer to any other members until later. That's fine.
Okay, we can start with you, Vice Chair Carlton.
Thank you, Madam Chair. So I guess what I have an idea of what we're trying to do. Thank you, Ms. Bond and Ms. Holmes. It's always nice to see you and work with you. You guys are so smart when it comes to some of this stuff. I know Nevada has kind of a pseudo corporate practice of medicine. The physicians have to be involved in the actual practice. But what I'm hearing is that these private equity firms are coming in and buying some of these practices up. So the doctors are still involved, but they're really owned by the private equity firms. And we know a private equity firm has a fiduciary duty to its shareholders, not necessarily to the practice of medicine. So I'm just trying to understand. So basically what you are asking for is transparency in being able to see who these doctors actually work for. And the way you propose to do that is on the yearly or biennial registration, just basically have the doctors fill in another line stating who actually are the major players in their company or their practice. And I just want to make sure I made that straight, because it was, we did lose you a little bit off and on. So if you could just clarify that.
Madam Chair, through you to Vice Chair Carlton, if I can just take the first shot at that, that's absolutely right. We don't have a lot of transparency in our system around ownership, like almost none. And we do see it in private equity buying up these practices. But we also see it in your first issue that you raised, which is the corporate practice of medicine. We are unclear at this point what the hospitals are doing with the physician practices, but we know it drives up cost when they own the practice, because a facility fee is then added to the practice that didn't exist previously. So there's ways that this is all generating a cost impact, it also an access impact. Also, we're not sure if it's having an impact on the doctors themselves, which we so desperately need to keep. And we don't have enough data to even start measuring it.
Thank you. I appreciate that. For too long in this building, we've made a lot of decisions based on anecdote and not data. And I'm so pleased to see that we are moving towards getting all that data. On the registration piece, though, so do you know, and maybe this is more for the board later on, but I believe they've gone to a lot of digital registration, online registration. So this would basically be just adding another section to their registration to fill out this information, and then they would compile it and forward it to HHS once a year or once every 2 years. Is that the procedure that you would see?
Madam Chair, again, I'm sorry, through you to Vice Chair Carlton. I'm just answering because I told Maya I'd take the questions. So if Maya has more to add, or if the Assemblywoman does, Assemblywoman Duran, please interrupt me. But yes.
Members.
Okay. Yes. So because the physicians have to apply for their licensure and then renew their licensure, this was the easiest place to put it. But if we agree that it should be digital if possible, and there might just be fields that can be added to the digital applications rather than this form that's in this bill right now. We could present a conceptual amendment that would simplify this process, because if both boards are operating digitally, it would be way better to do it. And then that electronic file could just be lifted to DHHS instead of another piece of paper having to move around.
Okay, thank you, Ms. Bond and Ms. Holmes. Thank you, Madam Chair. I believe that answers my questions. Thank you very much.
Okay, Assembly members, any other questions? Okay, Assembly Member Kasama.
Thank you so much, Chair. Two questions, if I may, and thank you for the presenters. Again, it's Assemblywoman Heidi Kasama, District 2. Will we be hearing from the physicians groups as far as impact, or if this can be done, or what their input is on that?
Assemblywoman Kasama, I believe the insurance groups would probably be in the testimony portion of the hearing.
Okay, wonderful. And then if I may, one other question. So I see the goal of collecting this extra data, and I have a feeling my question will be answered when I hear their testimonies will, but I'm just wondering what the end goal is with all the data, because it sounds like we already know that we have equity acquisitions are growing, and usually when that happens, it's because the doctors aren't making enough money, whether it's Medicaid reimbursement or what the issue is there. So they're not making enough money, or their overhead isn't good enough, so they're being attracted to these groups or consortiums. So I'm just wondering what the end goal is with all this data, because it sounds to me like this consolidation is usually due to money, and having more of the data, how would that fix it? Is it a burden? And perhaps it won't be a burden. I'll find out. I'm just curious.
Madam Chair, to Assemblywoman Kasama, thank you for the question. I don't know that we know what's driving physicians to sell their practices. I think that's part of the mission here, is to see if there's a trend in acquisition that continues, if it seems to be related to one specialty. I don't know that it's income related. And I don't know if the physicians even make more after they sell their practice to private equity. And those are all questions that would be wonderful to have as a policy program in the state. But we're just trying to start collecting the data to see if there's any trends.
And Ms. Bond, if you would just identify yourself when answering questions, and then you can also go directly to the member.
Okay, thank you, Madam Chair.
Okay, I have Assembly Member Tolles with questions.
Yes, thank you, Madam Chair, and thank you to all the presenters. I just wanted to check and see, because I didn't see it anywhere in the language, what happens if a physician either fails to or refuses to answer these questions? Is there any kind of penalty?
Bobette Bond for the record. Thank you, Assemblywoman Tolles. I don't see in the bill that there's a remedy for that at this point. I think that would have to be some discussion about how that would be, how physicians would be treated. It seems like, again, this is an ideal process because they're required to complete their licensing application and renewal in order to stay licensed. So it seems like a simple way to make sure everybody's getting the data in.
Thank you. Maybe that might be a question for, it's the licensing board, right, that would collect this, the Board of Medical Examiners and the State Board of Osteopathic Medicine. I just wonder, I've looked at similar types of proposals. I was actually going to bring a different kind of data collection proposal, but just wondering if they would not renew the license if they didn't fully complete that, or if so maybe that's a question that's better for the boards.
And if I may, Madam Chair?
Yes, Assemblymember Duran.
This is Assemblywoman Duran. To Assemblywoman Tolles, we are still going to try to amend some of the language and also check with LCB to see if there's any other costs or penalties that can incur with this. So we don't want it to be punitive. We just want to collect data to make sure that Nevada is not going to, we need choices for our doctors. That's kind of the bottom line for all our family. We need quality, good health care. And, when we don't have doctors that, are leaving, we don't have much of a choice. So I think that's primarily our goal, is to make sure that Nevada is still has a choice for our constituents across the state to have a good choice of doctors.
Thank you. Thanks, Madam Chair, for the questions.
Assemblymember O'Neill.
Thank you, Chair. My question is twofold. One, how many other states have done such a requirement? And two, has it shown to reduce the cost of healthcare / improve healthcare delivery to the communities in those states?
Assemblyman O'Neill, Bobette Bond for the record. I believe that we would have to do a pretty deep dive to see what information every state board requires as part of licensing. So we don't have that information available today on what's required as state licensing nationally. I do think there is a growing need to understand how the markets are changing nationally with the private equity issue, and also with physicians being purchased by hospitals more frequently.
Ms. Bond, we lost you again. If you can hear me, Ms. Bond, we might need you to re-answer that. We lost connection with you.
Okay, I would say that this is about transparency. This legislation is about creating the transparency to then answer the next questions that some of you, the assembly people, are thinking ahead of the net impact later on. But you need the transparency to even see if there's a relationship, and we can't even see that right now.
And Chairman Hargi, if I could just add, this is Maya Holmes for the record, to respond to Assemblyman O'Neill.
Yes, Ms. Holmes, sorry, I was on mute, but yes, please, when you're ready.
Okay. I just also wanted to add to Bobette's comments that it's very clear in the data and the research that healthcare consolidation is the leading, if not the driving factor in increasing healthcare costs. And I think, as Assemblywoman Carlton raised earlier, this is really about having the data so we can begin to understand and address what's happening. And it's very hard to make really, I think, informed policy that we, want to be in a position to make without that data and just kind of relying on anecdote.
If I may follow up, Chair, with Ms. Holmes?
Yes, Member O'Neill.
I appreciate you wanting to collect the data, but I think would you admit or say that there could also be other factors besides consolidation of doctors in their practices, such as the cost of medical school, the cost of running a business, the personnel costs, et cetera? Those could also contribute? Instead of just consolidation? I'm hearing you say you just want the data of consolidation, and I think there's probably other data factors that could contribute to the cost of health care.
Yes, Chairman Hargi, or through Chairman Hargi to Assemblyman O'Neill. I agree. I think there's probably multiple factors. I think the research has just shown that consolidation is such a critical factor, and that's a piece we don't have. So, but I definitely agree. Healthcare is complex, and there are a lot of factors. So we're just trying to pull the information together so we have a full picture.
I appreciate that. And Ms. Holmes, as I think Chair asked, I missed all your statistics at the beginning of the presentation. So if you could get those to us, I would really appreciate that. So, and thank you, Chair, for the time. I appreciate it.
Thank you, Assemblymember O'Neill, for your questions. Assembly members, any other questions? I'm checking the chat and I don't see any there. So I'm going to look at the screen. If there are any questions, just raise your hand. Okay, seeing none, we will move into the testimony portion of the bill hearing. We will start with testimony in support. Broadcasting, can we check the telephone line for anyone wishing to testify in support?
Yes, Chair. To testify in support on AB 278, please press *9 now to take your place in the queue. Again, if you would like to testify in support on AB 278, please press *9 now to take your place in the queue. Caller with the last 3 digits of 643, please slowly state and spell your name for the record. You will have 2 minutes and may begin. Caller with the last three digits of 643, please press star 6 to unmute.
Hi, my name is Stacy Sasso. I'm the Executive Director for the Health Services Coalition. The coalition represents 25 employer and union-sponsored health plans in Southern Nevada with an estimated 300,000 lives. Our focus has always been on bringing quality, affordable health care to the lives we represent, and we are testifying today in support of AB 278. We feel transparency in the healthcare market will continue to ensure patients in our state have access to providers. Understanding the changes in the marketplace will help patients navigate their health care and make informed decisions on where they seek care. Oftentimes, changes in ownership take place without notice and cause unexpected consequences to patients and payers. We appreciate the work that's being done on this issue. Thank you.
Thank you for your testimony. Broadcasting Services, next caller, please.
If you recently joined the call and would like to testify in support of AB 278, please press star 9 now to take your place in the queue. Caller with the last three digits of 333, please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Hi, my name is Donna Kelly, and it's spelled DonnaKelly-YU. Hello, Nevada legislators. My name is Donna Kelly, and I'm speaking in the support of AB 278. I have been a culinary union member for 22 years. As someone with underlying health conditions, I have had to change my primary doctor before, and that has become difficult as someone who wants to be empowered and informed patient. My husband and I have had a primary health care physician for a couple of years, and he was great. He was the doctor who diagnosed me with my diabetes and explained the diabetes to me, prescribed me medicine, and gave me a sheet of paper with suggested foods that I should eat. I was able to lose 40 pounds under his care. My health improved so much under his care, I felt great. He was kind, caring, encouraging doctor. I would even have to drive 30 minutes each way to see him. Everything was going great until I found out that I could no longer see him, and I never found out why. It felt like a setback, and I had to build a relationship with a great doctor, and then all of a sudden, he was no longer available. As a patient, I am concerned about rising health care prices and our access to quality doctors. Doctors are changing hands all the time. Sometimes they get bought out by big hospital systems or large corporations, and I am worried about how that impacts my health care. Patients should have information on what is happening with our doctors, who owns their practice, and how the changes will impact our health care access, quality, and price. I urge Nevada legislators to support AB 278. Thank you. And my name is Donna Kelly. Thank you so much.
Thank you, Ms. Yu, for your testimony. Broadcasting, next caller, please.
Caller with the last three digits of 018, please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Good afternoon. My name is Jim Sullivan, JIMSULLIVAN, and I'm representing the Culinary Union. The Culinary Union supports AB 278 because healthcare affordability, quality, and access are critical concerns for 60,000 Culinary Union members and their families. The Culinary Union, through the Culinary Health Fund, is one of the largest healthcare consumers in the state. The Culinary Health Fund is sponsored by the Culinary Union and Las Vegas area employers. It provides health insurance coverage for over 145,000 Nevadans, the Culinary Union's members, and their dependents. The Culinary Union supports efforts to bring transparency to healthcare to the healthcare industry and to understand market forces in Nevada's healthcare market. This information is critical for the state, policymakers, employers, payers, and patients because market forces can reshape healthcare, and we should have data to understand what is happening and the impact. The Culinary Union urges the Nevada legislators to support and pass AB 278. Thank you.
Thank you, Mr. Sullivan, for your testimony. Broadcasting next caller, please.
If you recently joined the call and would like to testify in support of AB 278, please press star 9 now to take your place in the queue. Chair, there are no more callers in support at this time.
Thank you, Broadcasting. Next, we will hear testimony in opposition. Can we check the telephone line for those wishing to testify in the opposition?
Yes, Chair. To testify in opposition on AB 278, please press star 9 now to take your place in the queue. Caller with the last 3 digits of 020, please slowly state and spell your name for the record. You will have 2 minutes and may begin.
For the record, my name is Jim Wadhams, W-A-D-H-A-M-S. I'm here today speaking on behalf of the Nevada Hospital Association in opposition to AB 278. We have just experienced, under the leadership of Governor Sisolak, a declaration of emergency for the COVID-19 pandemic, and all of us have witnessed the incredible resourcefulness of medical professionals, from physicians to nurses and other health staff. We are concerned that this bill places a significant burden upon the very people we rely upon for our health care in terms of additional reporting, potential encroachment on personal information, and we are concerned that this may discourage the investment in our healthcare system that is so critical as we face this pandemic. We look forward to continuing to work with any other stakeholders should the committee decide to move forward and further discuss this bill.
Thank you for your testimony. Thank you for your testimony, Mr. Wadhams. Broadcasting, can we check the telephone line for any other callers?
If you would like to testify in opposition of AB 278, please press star 9 now to take your place in the queue. Chair, there are no more callers in opposition at this time.
Okay, thank you. We will now move into the neutral testimony. Can we check the telephone line to see if there's anyone wishing to testify in the neutral position?
Yes, Chair. If you would like to testify in neutral on AB 278, please press star 9 now to take your place in the queue. Caller with the last 3 digits of 058, please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Good afternoon, Madam Chair, members of the committee. This is Keith Lee, K-E-I-T-H, last name Lee, L-E-E. I'm here today on behalf of the Board of Medical Examiners. The Board of Medical Examiners is neutral on the policy in AB 278, but has some questions regarding the implementation and effect of AB 278, and I have shared those with the sponsor. And very quickly and briefly, specifically, given the acknowledged shortage of healthcare providers in Nevada, the question is, if the applicant for renewal does not even attempt to fill out the questionnaire, do we, the Board of Medical Examiners, immediately deny relicensure, or is there a grace period? And I would refer, while the bill itself does not mention what the remedy is, the LCB's digest suggests that as the Board of Medical Examiners' current existing law, NRS 630.3065, empowers the Board of Medical Examiners to deny licensure if a knowing or willful failure to perform any statutory obligation is presented itself. So I think that, at least according to LCB's digest, the remedy would be a specific denial of the relicensure, and so we would seek clarification on that. Additional questions. If the applicant for renewal submits the questionnaire but does not answer all the questions, do we deny deny relicensure? Likewise, who is the entity that would determine if the submission of the answers is sufficient to meet the statutory requirements? And finally, we, the Board of Medical Examiners, would prefer not to be the recipient of the answers, but merely to be a middleman to assist in getting the questionnaire answered. And I would suggest, in answer to Vice Chair Carlton's questions, we, the Board of Medical Examiners, have instituted a new electronic application process where we can provide, in the application for relicensure, we can provide a link that would directly go to the DHHS questionnaire and have the answers go directly to DHHS. And that would be, then we would only be the facilitator to have those questions answered. And the beauty of this new application process is if the applicant for relicensure fails to click on that link to open the questionnaire, then the applicant cannot proceed further with the application, and it will be an incomplete application for relicensure. And finally, we have a question for legal. In order to maintain the confidentiality of this information, we would ask, do we need to amend NRS 630.220 and/or 630.339 to provide for specifically for the confidentiality of this information? Finally, Madam Chair and members of the committee, we look forward to working with all the interested parties on this bill and to resolve some of these questions that we have and any other matters that might expedite the fulfilling of the statutory obligation presented in AB 278. Thank you, Madam Chair.
Thank you, Mr. Lee. Please stay on the line. I do have a question for you from our Vice Chair. Vice Chair Carlton?
I shall. Thank you.
Thank you very much, Madam Chair, and thank you, Mr. Lee, and thank you for being a half a step ahead of me on the digital side. As far as the concerns about filling out the form and the licensure, we ask folks on a lot of different forms to fill things out, and if they don't, they all have to comply with the standard repercussions of that. So I would assume that's where we're going, but I look forward to you being able to work with the sponsor on the bill and make sure that we answer that. As far as the digital goes, so if you could explain to me right now exactly how folks, because I know there's questions about the burden of being able to fill this out. So if I understood you right, and it broke up a little bit, you would basically have a link on your application and it would go right to a form with HHS, but they wouldn't be able to complete the application until they completed that form. Is that correct?
Madam Chair, Keith Lee for the record. I misspoke if that's the impression I left. My understanding of how our new application would work in particular reference to the issues at hand here is that we could provide in the application for relicensure that's now electronic, we could provide in that a link that the applicant for relicensure would have to click on and to supply the answers. If the applicant did not click on that link, then the applicant could not complete the application for relicensure. So that would be, in other words, if the applicant did not click on the link to the questionnaire and to DHHS, the application for relicensure would be incomplete until the applicant did that. So that would be the assurance that at least the applicant clicked on the link to go to the questionnaire to assure that for relicensure purposes.
And if I may, Madam Chair, but there would be, so by clicking on the link, they would be able to fill it out, but on the back side of that, they could fill it out and put in a bunch of X's and a bunch of dashes and not answer the questions, but they would still get their license because they clicked on the link and filled something out. So there's really not an accountability factor there.
Madam Chair, Keith Lee for the record. That's correct. There is not an accountability built into the statute, but we can build in several different ways. We can put a certification in that application for relicensure that the person has not only clicked on the link but has answered the question. We can also provide some method, and I'm not quite sure how we do it, but a method with DHHS that they would confirm back to us that the application or that the questionnaire has been filled out. So I think there's a method to do that. I would suggest, and I did a little bit of research on this. Last session, 2019 session, SB 171, which ultimately did not pass, but has a provision similar to what we're talking about here, where
Mr. Lee, are you there?
Chair, the caller seemed to have dropped.
Okay. Okay. If we get him back on the line, is there a way to identify whether he jumps back on the line with the last 3 digits of his telephone number?
I apologize, Chair. I was not able to, I don't have a record of what the last 3 were, so I don't have that in hand. I apologize.
No worries. Vice Chair Carlton, would you be able to take your questions offline?
And thank you, Madam Chair, very much. And because the board was in neutral and because they're the ones that are going to have to implement this, I just wanted to get a feel for myself and for the committee on what the ramifications of and how this would work. So it was very helpful in what he was answering. The only other question that I had was on the confidentiality side, but I'm sure he's going to be reaching out to the sponsor of the bill and to the other members. I understand confidentiality to what I think he's trying to get at, but we don't want it so confidential that we can't get the data and really study what's going on. So I think there's going to be a real balancing act there. And I'm sure the sponsor and the proponents of the bill will be working with the board to make sure that we get good public policy. So thank you very much, Madam Chair.
Thank you, Vice Chair Carlton, for your questions. Broadcasting, could we go back to the telephone line, please, to check to see if there is any other callers in neutral?
Yes, Chair. To testify in neutral on AB 278, please press star 9 now to take your place in the queue. Caller with the last 3 digits of 080, please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Thank you. Thank you, Madam Chair. For the record, Susan Fisher, SUSAN-FISHER, with McDonald Carano, speaking today on behalf of the Nevada State Board of Osteopathic Medicine. Like the Board of Medical Examiners, we are neutral on AB 278, but we do have concerns as well. I don't have an official position while I say that I'm neutral, because our board has not had an opportunity to review this in an open meeting, subject to the open meeting law. So I am speaking in the neutral position right now. We do already gather a lot of information, as you know, and the bill does require us to gather information through our renewal process and then forward the information as we get it to the DHHS. This means that we will possess the information in our computer system first and then send it to the DHHS. So our initial thoughts are that we're a little bit uncomfortable having that information if it was provided in in a link that just goes directly to DHHS. That would give us a little bit better comfort level. I would also point out that according to our statutes, if a licensee or an applicant does not complete every single question, we do not process the applications. So we process our initial licensing and our renewal applications very quickly. However, if there is missing information and we have to go back to the applicant, that holds up the licensure. So we are a little bit concerned about the risk of losing practitioners who don't want to provide what they may consider intrusive information to the state. Section 2, subsection 4 of the bill does state that the data is to be confidential and not disclosed to any person or entity outside of DHHS. And I think that covers most of our concerns at this time.
Thank you, Ms. Fisher, for your testimony. Broadcasting, next caller, please.
Caller with the last three digits of 058, please slowly state and spell your name for the record. You'll have 2 minutes and we begin.
Madam Chair, Keith Lee again. I apologize for something apparently I dropped off in answer to Vice Chair Carlton's question. Let me see if I can pick that back up. Right now, we suggest that there be a link directly to DHHS, and I believe the question was, how do we confirm that, in fact, the link was clicked on and answers were given? And there's a couple of ways to do that. One, we can include in our relicense application a certification that the applicant has not only clicked on the link but answered the questions, or we can also go back and confirm with DHHS that the questionnaire has not only been clicked on but has been answered to the satisfaction of DHHS. And I refer to a bill from last session, 2019 session, SB 171, which did not ultimately pass, but in which we dealt with a similar issue with information from the applicant to the University of Nevada, and we developed a system through that. My recollection is that allowed the Board of Medical Examiners to confirm that the questions that the questionnaire had been answered. So I think there's a way to deal with a confirmation that the answers, or that the applicant has in fact answered the questions. But we can work with all the folks involved, particularly the DHHS folks and their computer folks and Board of Medical Examiners computer folks to figure this all out.
Thank you, Mr. Lee, and I appreciate you getting back on the line to finish answering the questions so the committee could hear it. Thank you. Broadcasting.
Sure. Thank you.
Next caller, please.
Chair, there are no more callers in neutral at this time.
Okay, thank you. Assemblymember Duran, would you like to give any closing remarks, you or your co-presenters?
Yes, and I just want to say my part of it. I thank you, Chair Housekeeping and the committee for allowing us to present AB 278 today. AB 278 is an initial effort to monitor healthcare consolidation and protect competition between healthcare facilities. It is not a question whether consolidation is good, but the question which must be answered is how investment in consolidation will provide patients access to cost-effective, high-quality care in Nevada. I am happy to work with any and all stakeholders of AB 278 going forward, and I ask your support of AB 278. Thank you.
Thank you, Assemblymember Duran, and thank you again for being so flexible and jumping in front of AB 274. I appreciate that. Thank you. Okay, I will now close the hearing on Assembly Bill 278 and go to our last bill for the day, Assembly Bill 274. I will open the bill hearing on Assembly Bill 274, which requires certain health plans to cover fertility preservation services. We have Assemblymember Gorlow here to present the bill. Welcome to the Assembly Committee on Commerce and Labor. Ms. Gorlow, when you're ready, the floor is yours. Oh, I believe you are on mute, Assemblymember Gorlow.
Yes, I was. Thank you. Can we hear me?
Yes, we can.
Okay, great. Thank you, Chair Housekeeping, members of the Commerce and Labor Committee, and I truly appreciate your flexibility. For the record, I am Michelle Gorlow, representing Assembly District 35 in Clark County. And this afternoon, I'm presenting Assembly Bill 274, which, as you mentioned, requires certain health plans to include coverage for standard fertility preservation services. I'm joined by a panel of supporters and experts that will offer their input, share personal stories, and answer technical questions for the committee. However, I'll begin by talking about fertility preservation in general. Fertility preservation describes a variety of treatment options that allow patients to have children in the future. Examples of fertility preservation procedures include sperm banking, egg freezing, and in vitro fertilization with embryo freezing. And while everyone can access these services, preservation procedures are disproportionately used by people with conditions that cause or lead to infertility. For instance, cancer patients may opt to receive fertility preservation services before undergoing radiation and/or chemotherapy treatment, which have been linked to cause infertility. The Alliance for Fertility Preservation estimates that of the 125,000 people under the age of 45 diagnosed with cancer nationwide, about half will receive treatments that will affect their ability to have children. Fertility impairment is often a major concern for young and reproductive age adults who would like to have the freedom to have a family in the future. In fact, a survey conducted by the Journal of Clinical Oncology found that 30% of breast cancer patients reported that infertility concerns affected their treatment decisions. So no one should have to choose between cancer treatments on the basis of their fertility effects. Likewise, no cancer patient should be discouraged from starting a family because pregnancy is too expensive. AB 274 seeks to provide men and women with health conditions the opportunity to access fertility preservation by mandating insurers to cover basic procedures. As per the bill in Section 1.5C, standard services for fertility preservation is defined as the procurement, cryopreservation, and storage of gametes, embryos, and other reproductive tissue for fertility preservation. The bill limits insurance coverage to two categories of people. The first category includes those with medical or genetic conditions that may directly or indirectly cause infertility. And the second category of covered persons are those expected to receive medical treatments that may also directly or indirectly cause infertility. For all intents and purposes, qualifying conditions and treatments will be established by the American Society of Clinical Oncology, the American Society for Reproductive Medicine, and the American College of Obstetrics and Gynecologists. Public and private insurers alike would be required to provide coverage to qualifying persons under the measure. This would include insurance plans covering fraternal benefit societies, group and blanket health, health insurance for small employers, HMOs, individual health, Medicaid, nonprofit corporations, and public employees. Ultimately, AB 274 is a life-affirming bill. It gives hope to people diagnosed with diseases that do everything to extinguish it. We have been communicating with stakeholders in the insurance market to understand and work through their concerns. I am now going to turn it over to Lindsay Knox, Vice President of Government Affairs at McDonald Carano. She has developed a conceptual amendment that is available on Nellis for the committee's review, and which will address also some concerns. After Ms. Knox presents, then we will turn it over to Kendall Sabino, and hopefully followed by Dr. Zucker. Although Dr. Zucker may be gone, he has patients to see this afternoon. So thank you very much.
Thank you, Assemblymember Gorlow. Ms. Knox, when you're ready.
Thank you, Assemblywoman Gorlow and Chair Howdy and committee members. Lindsay Knox with McDonald Carano for the record. As she stated, we have a conceptual amendment that we have worked on to try and alleviate some of the concerns that insurance has. So one of the main changes is the effective date. We are going to change that from July 1 to January 1st, 2022. This will allow the plans to properly prepare if this bill were to pass. Another part of the amendment will also include in the Medicaid section a waiver. Now, the reason we did this is initially we were concerned about having Medicaid in the bill due to the recent cuts and putting an additional burden on the state for that coverage. So what the waiver would do would allow the director to file a waiver with the CMS, as well as make an amendment to the state plan. This would allow them additional time to get things prepared. So this bill would actually, for Medicaid, would probably become effective January 1st, 2023. And then the last that we currently have would be for the self-funded plans, providing an opt-in provision, understanding that there are certain self-funded plans that have truly struggled during the pandemic, and to cause more burden would just be unfair. So we are working with the Health Service Coalition on an amendment in hopes that we can come to a resolution there. We know that there will be more issues coming, and we are happy to work with all stakeholders and hopefully come up with, again, some tighter language to make everybody happy.
Thank you, Ms. Knox. I believe we have Mrs. Sabino next.
Can I actually, I hate to interject, but I wanted to actually introduce Kendall myself, so I apologize. Kendall came to me about back in June of 2020. I sit on the Susan G. Komen board here in Nevada, and Kendall was interning. And Kendall told me her story and asked me to help her figure out a way to get fertility preservation here in the state. So her story was so touching to me, and I hope to all of you. And so from there, I will turn it over to Kendall, and thank you, Chair, for allowing me to step in and introduce her.
Absolutely, Ms. Knox.
Hi, good afternoon, everybody. Thank you, Lindsay, for that wonderful introduction. My name is Kendall Sabino. I am a first-year medical student at the University of Nevada, Reno School of Medicine, and also a breast cancer survivor. About a year and a half ago, during my last semester of college at UNLV, I was diagnosed with breast cancer. Receiving the news as I sat by myself in the radiologist's office was the worst day of my life. A cancer diagnosis is incredibly devastating, and anyone who's received the news themselves or has a loved one who's been diagnosed knows this. Now, when you think of cancer, you typically think of losing your hair, chemotherapy, radiation, all of which I went through last year. But what doesn't really come to mind, and what I didn't know about prior to my own diagnosis, was fertility preservation and the possibility that the toxic effects of chemotherapy might render me infertile. So prior to starting chemotherapy, I was recommended to visit a fertility specialist. And unfortunately, these services, the fertility preservation procedure itself, which involved extracting eggs and freezing them, a term called cryopreservation, or the drugs or the visits, none of this was covered by insurance, the way that the majority of my cancer treatment, thankfully, had been covered by insurance thus far, which I am thankful for my family and I. But for fertility preservation, this was a burden that my family and I had to bear, and it was an enormous cost of ensuring that I might have a family in the future. And personally, for me, this felt like one more unfair item added to the long list of the concomitant struggles associated with a cancer diagnosis, on top of dealing with cancer as a full-time college student preparing for medical school and during my 20s. It was a lot to bear. So last summer, I became involved with Susan G. Komen through an internship. And one of the goals that I had was to see if I could make change on fertility preservation here in Nevada. I was aware that some other states provide insurance coverage for patients that are undergoing chemotherapy, like myself, or are receiving medically necessary treatment that would similarly induce infertility. And I realized in my position as a future physician, but now also as a cancer survivor, that I had the voice, the advocacy, and the title to speak up not only for myself, but for my future patients, and not only my future patients, but many, many other patients here in our state of Nevada. And so I got connected to the wonderful Lindsay Knox and also Amanda Klein. And then soon our small team began to double in size, and it started growing into the tremendous number of supporters that we have today. And it is amazing to see this change taking place right before my eyes. And I am so grateful to be here today and to share the importance of this bill and what it would mean for so many for it to be passed. So thank you, Assemblywoman Gorlow, for introducing this bill, and thank you to everyone today for taking the time to listen to my story.
Thank you, Ms. Sabino, for sharing your very personal story. I know how difficult that can be, and for being brave to be here and take on that initiative. Thank you so much. Assemblymember Gorlow, I believe we still have Dr. Zucker on with us. Dr. Zucker, when you're ready.
Hopefully you guys can hear me. Good afternoon, Assemblywoman Gorlow and members of the committee. My name is Jacob Zucker. I'm a pediatric, adolescent, and young adult oncologist currently practicing up here in Reno. And I thank you for the opportunity to speak in support of Assembly Bill number 274 today. Especially, I want to thank our last speaker for just an incredible introduction of this bill, because she is the reason why I feel passionately about this bill. She's the embodiment of why it's important. And so please do have that be the image in your mind as we move forward with this bill, because it really is the most important. I'd like to take a real quick moment of my allotted time to introduce myself. I'm third generation of physician in my family to practice medicine in the great state of Nevada. My grandfather and father before me have both built incredible reputations for their exceptional care and patient advocacy. My grandfather in the South and my father up in the North had lasting impact on countless Nevada families and both helped to shape the landscape of medicine in the state. It's clearly within my DNA to advocate for all of our patients here in the state of Nevada, and that's why I'm speaking on behalf of the Assembly Bill today, number 274. Almost 5 years ago, I moved back to Reno, and I established a local hospital-based pediatric, adolescent, and young adult program to serve Northern Nevada families so that they could receive their care, oncology care, right here in their communities. My purpose was simple: to provide safe and effective oncologic care and to obviate the unnecessary travel, expense, and emotional burden of all of their care. Our program to date has received national and international recognition as a member of the Children's Oncology Group, and in keeping with that original purpose, I really do feel that we have eliminated a tremendous amount of stress and burden for our Northern Nevada families, such that they can concentrate on their care and on their health. This is a theme that you heard by our last speaker, and also one that I'll continue with in the rest of my presentation. In my current practice, I see patients ranging in age from birth to 25 years of age. Sometimes I'll see patients up to 30 years of age. My patient population overlaps very nicely with the adult oncology colleagues that I have in town, specifically in what we define as the AYA, which is the adolescent and young adult population. Together, the range of 15 to 40 constitutes approximately 10% of all the diagnosed cancer cases each year. And importantly, a statistic that I hope you all take to heart is that 80 to 85% of this population will indeed survive their disease. Unfortunately, enduring the therapy and surviving cancer is not the only challenges the patients face. My patients, especially those who are younger at the time of their diagnosis, will be faced with long-term health, emotional, and even financial burdens of their therapies lasting well beyond the completion of their therapy. There's a bright side in that there have been great efforts that have been made to mitigate the late effects of their therapy. Current trends focus on primary prevention, reducing toxicity in cancer regimens, as well as secondary prevention through close follow-up and survivorship clinics, which are considered to be a standard and included in the comprehensive care of patients, included in their insurance payments. Quality of life for our survivors is indeed improving. However, there's still areas of survivorship that are only now starting to receive proper attention. Fertility preservation is one of those areas for improvement. The risk of infertility varies with diagnosis and prescribed therapy. Nearly all patients who will be receiving chemotherapy will be at some risk of sterility or infertility, but a majority of them, and that's that 50% statistic that you had heard, and I would actually argue in my population higher, are at risk for either moderate or high, or are at moderate or high risk of infertility and sterility. Therefore, unfortunately, as part of my initial meeting with patients, I'm faced with delivering some of the same information time and time again. Number one, your child or you has a cancer diagnosis, which is life-threatening if left untreated. Number 2, you or your child will receive chemotherapy with the intention of curing your disease. However, the therapy itself may cause extreme or even life-threatening toxicity, and you will be at risk of another cancer caused by the medications we're treating you with. And then number 3, unfortunately, is your life-saving therapy may prevent you from being able to conceive biological children. My discussion with the patients and their families oftentimes differs ever so slightly, but one thing doesn't change. You have cancer, your treatment may cause health problems, you may even have another cancer in the future, and your treatment may render you infertile. There is no way around it. In that initial discussion of the cancer diagnosis, a patient and or their family loses control, some control over the outcome. And at least that outcome, the control over the outcome, is tremendously challenged. They're left feeling powerless over their disease and of their future. This feeling of being powerless contributes directly to other comorbidities to include depression, anxiety, and even sometimes deconditioning. Any control over that outcome that can be restored has profound and positive impacts on patients, their well-being, and even indirectly on other healthcare costs by eliminating those comorbidities. The tone of the conversation can immediately change if we add to the discussion, your life-saving therapy may prevent you from being able to conceive biological children, but we do have a solution. And there is a solution, and that's fertility preservation. Fertility preservation is a standard of care in AYA oncology. It should be offered to every patient who has risk. More to the point, I very much advocate for legislation which not only makes fertility preservation an option, but makes it feasible for patients and families who are already struggling with the financial burden of their underlying disease. There are many, many, many factors which ultimately influence a patient's decision to pursue fertility preservation. The most common barriers include, but are not limited to, the age of the patient. If they're too young to be able to undergo procedures, too young to be able to donate or bank sperm. The timing of their cancer therapy, I'm often challenged with having to start therapy, life-saving therapy on a patient, and balancing that with the amount of time that it would take to go ahead and proceed forward with fertility preservation. But unfortunately, a third barrier, oftentimes it comes up, is regarding cost to the patient. Of the 3 barriers listed, we are left with little option regarding the first 2. However, the third option is one that really we should ensure that cost is not a deciding or a dissuading factor for the patient. I do want to share with you a story of a 19-year-old patient of mine who just completed the process of fertility preservation and provided me with the following direct quote. No one decides to be infertile. The expense of already having to deal with medical bills associated with childhood cancer, as well as the physical and emotional trauma that is caused, is already more than anyone should have to handle. Going through fertility treatment at such a young age under these circumstances is already stressful enough. Wondering how to pay for college is already stressful enough. It is my hope that no teenager would ever have to decide between paying for fertility preservation and purchasing college textbooks. It is clear from the statement that the fertility preservation is a topic that matters to our patients, especially our AYA patients, especially our young adults. Infertility is associated with depression and low self-esteem and is often a source of disruption in family dynamics and planning. There have been many studies have shown, and I have many, many cases where patients have requested that their therapy be changed, altered, or even compromised to avoid infertility or sterility, and thus increasing the risk for treatment therapy failures and for mortality. These are not decisions that any teenager or young adult should have to make. So in summary, fertility preservation should be offered and included in the comprehensive care of our adolescent patients and young adult cancer patients. The number of patients who will ultimately be appropriate for fertility preservation is proportionally small, and therefore the overall cost of the service too is actually relatively small. The benefit, however, to the individual is great and would be in keeping with mitigation of unnecessary stress and burden for this patient population. And again, Chairman, as well as Assemblywoman Gorlow, and thank you to all the members for being able to hear me. This is an exceptionally important subject. You just saw right before your eyes a real patient with a real story of why this is so important, and I encourage you to give great consideration to this bill.
Thank you, Mr. Zucker, for being here and for hanging on for us. It was important testimony and a presentation that you had, and thank you for the work that you do in our community as well. Assemblymember Gorlow, are you ready for questions?
Yes, we're ready for questions. Thank you.
Thank you. Committee members, questions, please. In chat, I see Assemblymember Tolles.
Thank you, and thank you so much for the presentation, for bringing forward this bill, and thank you especially, Ms. Servino, for sharing your story. And as a mother of two daughters, I asked myself reading this bill, you know, how I would feel if they were in that same situation, and that I would want them to have this option as well. And so I really appreciate this legislation. I want to give just get a couple questions on the record. I did have a chance to speak with the proponents beforehand, so I just want to make sure I get those answers on the record so it's clear for others that might have those questions in the future. So on Section 1, subsection 5C, we have the definition for standard services for fertility preservation. And if you could just review what that includes and what that does not include.
Lindsay Knox, Assemblywoman Gorlow, do you want to take that?
Actually, I was just going to ask you to take it, so thank you.
Okay. So Lindsay Knox, for the record, through you, Chair, to Assemblywoman Tolles. So what that covers is the medication, the retrieval, and the appointments, and then the storage. And I believe that is everything that it covers.
Thank you. And I think specifically the question came up, does this cover in vitro fertilization?
No, it does not.
Thank you. And then the other question that arose was, do we have procedures in place for, unfortunately, if the life-saving treatment was not successful, what is the process for what happens with the, with the stored embryos and reproductive tissues and gametes?
Through you, Chair, to Assemblywoman Tolles, I have a very long answer and a short answer. I will keep it short. There are legal requirements for the clinics that address this. So where those get stored, those documents are signed there and reviewed.
Perfect, thank you. And just wanted to get that on the record that all the current procedures in place for addressing those concerns are already in place. Thank you so much.
Thank you, Assemblymember Tolles, for your questions. I have Assemblymember O'Neill next.
Thank you, Chair. I appreciate it. I really think I like this bill, and I appreciate Ms. Garlow bringing it forward. It's been an interesting discussion I've heard. But I've got a question. We talk so much with insurance payments, insurance companies, retroactivity or pre-existing condition. So, Dr. Zucker, you have a patient, hypothetically, that is still fertile or viable, but is going to be going under a therapy. They already have insurance, you've already harvested the embryo or sperm. They've already paid for it to go into storage. Is there any consideration? Does insurance companies pick it up then at that time? In other words, for those that have already performed this act and suffered the treatment plans, unfortunately, I don't think that came across well enough. Ms. Zucker or Ms. Knox, can you help me?
I can help you through you, Chair.
Direct the member, Ms. Knox.
Thank you. Assemblyman O'Neill, this is Lindsay Knox for the record. Yes, I know what you're asking. So you're asking pretty much on retroactivity. So if somebody were to switch insurance, would that storage then be covered when they switch? Did I get that right?
Yeah. Whoops. That they switch, or they've already gone through the process and they're storing. Would the insurance company pick up the storage fees now?
So they would not pick up the storage fees if it had been done prior. But what would happen is, let's say once this bill was implemented, what would happen is, if I'll just use myself as an example, If I went in after this bill was passed and implemented, had cancer, decided to preserve my eggs, and then let's say I switched jobs and I got new insurance, that new insurance would pick up that storage.
That's what I was looking at. I appreciate that. And I didn't hear it covered, but can someone answer what would be the approximate costs for the procedure, and then what is storage run? Is it time limited or is it an indefinite freezing?
Lindsay Knox for the record. Assemblyman O'Neill. So I have a little chart right here. Is the costs, and again, you're going to have different rates based off of your location. So for egg freezing, you're looking at the services cost between $10,000 and $15,000, which storage costing between $300 and $500 per year. Embryo freezing, $11,000 to $15,000. Storage, $400 to $600 a year. We'll shoot down to men. Sperm banking, service cost is $500 to $1,000. Storage is $150 to $400. And testicular sperm extraction is $75 to $10,000, and the storage is $300 to $500 per year.
I appreciate that. Would you, Chair, if you don't mind me, would you get that for us, and so we all have access to that, please?
Yes, you're reading my mind, Assemblymember O'Neill. Ms. Knox, would you provide that chart to our committee manager so she can upload it as an exhibit and share it with the committee members?
Yes, Chair, we will get that to you.
Thank you so much, Ms. Knox.
Thank you, Ms. Knox, for the information. Thank you, Chair, for the time. I appreciate it.
Thank you for the questions, Assemblymember O'Neill. Next, I have Vice Chair Carlton.
Thank you, Madam Chair. And I have 3 different questions, if I may. So in the interest of fairness, this is a question I ask everyone who brings one of these types of bills. And you heard it earlier on the first bill today. I'd like to ask the sponsor just to clarify that this is indeed an insurance mandate.
To you, Vice Chair Carlton, through Chair Howdigi, yes, it is an insurance mandate.
Thank you. It's always good that we make sure we have a clear record. And typically the mandates in the state don't apply to every form of insurance. I believe some of the ERISA plans are excluded. I'm not sure who could answer this, but I did hear conversations about Medicaid, and I'll have another question about Medicaid after this. But is it the intent that this would apply to all plans in the state, or are ERISA plans being exempted?
For the record, Assemblywoman Michelle Gorlo, and to you, Vice Chair, through Chair Howdigi, we are looking at options to opt in for some insurance groups, because we know that it can be a burden, especially with the self-funded groups, and we're still talking with other groups as well.
Okay. And if we could expand upon the Medicaid, I'm going to put my Ways and Means hat on. I have to wear it. I don't put it on in every committee, but I have to in this one because Medicaid was brought up. I'm just curious about if you could expand upon how this would work with Medicaid. And I just have a concern about the underlying costs that would come to the state for this. If we were to ask for the waiver, do we have any numbers? Do we know if would this be under the newly eligible FMAP? Does anyone have any answers to that? And if not, I understand they're fairly technical questions.
And Ms. Garlow, you can go direct to the member.
Thank you, Chair Howdigi. And for the record, Assemblywoman Michelle Gorlo, I do not have those numbers, but perhaps Lindsay Knox might have them.
Assemblywoman Carlton, this is Lindsay Knox for the record. We have not seen a fiscal note yet from the Medicaid office, so those numbers are still unclear to us. Again, that's part of the reason that we were putting in the waivers to give them additional time. But I would like to, again, see that fiscal note and understand what the impact would be. And like I said in my introductory comments, that is a big concern to me. I do not want to burden the state more than it already is. especially since one of our special sessions included a 6% cut. So I want to be very, very careful on how we approach that. So we will work to get those answers and get those to you.
And thank you very much. And it's maybe because of the way it was pulled together, and I believe that was part of if that was part of the amendment or wherever, we'll work on that and get there. But I think Madam Chair, this will be my final question. So I know since we passed the Affordable Care Act, and the insurance commissioner at that time was tasked with setting up the essential benefits plans, and it's my impression and recollection that any new mandate that comes in after the essential benefits have been established under the Affordable Care Act, there's a provision. I'm going to have somebody look it up. I only have to look at it every couple of years, that the state could be responsible for part of that because it's outside of essential health benefits. So I just want to put that on the record for our committee staff and for Ms. Knox to look into. I believe there might be some unintended consequences with adding a benefit outside of the ACA essential benefits. So I just wanted that on the record for the full conversation on the bill as we move forward.
Thank you, Assemblywoman Carlton. Again, Lindsay Knox for the record. We will definitely look into that, and I am already receiving text messages that we have an answer to that, so we will get that for you.
Thank you, Ms. Knox. If you could share that with the committee, that would be great.
Yes, Chair.
And Madam Chair, if I could also, if we do have an insurance representative from the Insurance Commissioner's Office available and/or our legal, I just want to make sure that we have all the information when it comes to that. Thank you very much.
Thank you, Vice Chair. It looks like the Division of Insurance hopped off, and our legal is currently drafting and not with us today. Okay, thank you. Members, any other questions? I don't see any in chat, so if I miss someone, just raise your hands really quick. Assemblymember Marzola.
Thank you, Chair. And my question will probably be for Lindsay Knox. Lindsay, has any other states passed legislation such as this that we're trying to pass now?
Assemblywoman Marzola, thank you so much for the question. Lindsay Knox for the record, yes. Currently, there have been 10 states that have passed this in some form, and we currently have 10 states that have active legislation. If you would like me to read those states in the record, I'm happy to, or I can just send you information once we're offline. You are on mute.
Sorry about that. No, if you can just send it to us, that would be great.
Absolutely.
Thank you so much. And then if I can just make a quick statement, Chair.
Yes, please.
I just wanted to say thank you to Kendall for getting on today, sharing her story, and using her story to make such a change for the state of Nevada. So I really appreciate it. Thank you, Kendall.
Thank you so much, and thank you all for having me here today.
Thank you. And I believe I have next Assemblymember Constantine. Did you have a question? I saw you and Ms. Marzola raise your hands at the same time.
Yes, Madam Chair. Thank you. I believe this question would go to Ms. Knox, and it may have already been essentially answered, but I just wanted to confirm it. From the way that the doctor was talking, I would assume there is a population of patients who would be eligible for something like this who are underage. So in that situation, I'm assuming that this would be under their parents' insurance. And then if you're looking at future storage, then at some point that would have to switch over to when that underage person becomes an adult and it switches to their insurance. And knowing that this is now in 10 states, has that process been fairly seamless? Is that already set out? Is that something that switches, like that responsibility switches to that now adult as opposed to it being under the parent?
Assemblywoman Constantine, this is Lindsay Knox for the record. Thank you for the question. It would switch over once that child became an adult and carried their own insurance. There's a little bit more to your question, and I think we're going to have to look to do a little bit more digging to see if it's been seamless in other states. I want to make sure I get you the correct answer and I don't say anything out of turn. So we will be sure to follow up with our folks that we've been working with that have done this in other states, and we'll get you that answer.
Thank you very much, and thank you for the question, Madam Chair.
Thank you for the question, Assemblymember Considine. Next, I have Assemblymember Dickman.
Thank you so much, Chair Hudigi. Just a quick question, maybe for insurance people, but the doctor did seem to tell us that this wouldn't apply to an awful lot of people, but it's also very expensive. And so I'm wondering if you have any just remote estimates on how much this could increase insurance premiums for the entire pool of insureds who are paying premiums.
Assemblywoman Dickman, Lindsay Knox for the record, I actually do have those numbers. So what we are looking at based off of, we have a Nevada utilization calculation, which I can also share with the committee. So we are looking at about 740 people that would actually be eligible for this in the state. And again, we don't know the exact cost from a Nevada perspective, but what I can say is that we have cost estimates that other states have done and what the premiums, the per member per month increase. And it's looking at, and this was in California, 1 cent per month, which would potentially go from 1 cent to 6 cents. So in that range. And then Connecticut was 10 cents to 24 cents.
That's for everyone who's paying an insurance premium.
You are correct.
Okay, thank you.
And thank you, Assemblywoman Dickman. I'll be stepping in for the chair for just a moment. So, Ms. Knox, if you could provide that, because we need to have those, we want to be sure and have that. I'm not sure about, I didn't quite hear every single number. So if you could provide the document, that'll just make it much easier for us to be able to look at. I know these treatments can be very, very expensive. So we just need to look at, be able to do the math on it from there. So thank you.
Of course, we will get all those documents to you.
Thank you. We appreciate that. So other members of the committee with any questions at this time? I don't believe I see anyone else wishing to be recognized at this moment. So with that, we will go ahead, Assemblywoman Gorlow will go ahead and go to those in support. So if we could go ahead and open up the phone lines, and if broadcast services would please queue up those folks in support, that would be great. Thank you.
Thank you, Chair. To testify in support of AB 274, please press star 9 now to take your place in the queue. Caller with the last 3 digits of 675, please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Hello? Can you all hear me?
Hi, we can. Yes, we can.
Okay, thank you so much. Good afternoon. I just want to thank the chair and vice chair and committee members for allowing me to speak in support of Assembly Bill 274. My name is Joyce Reinecke, and I am here to testify as the executive director of an organization called the Alliance for Fertility Preservation. We are a national nonprofit organization that's dedicated to helping cancer patients both understand and also navigate the reproductive consequences of their cancer treatment. But I am also here as a cancer survivor and had a diagnosis of cancer in my 20s. And just as you heard from Kendall, it's a terrifying process. And it's really difficult to deal with that diagnosis and have a threat to your life and then learn that your ability to have children would probably also be destroyed by your treatments.
I consider myself fortunate. I got really great medical care, and at that time it was unusual that my oncology team really shared with me, the fact that my fertility was at risk. My husband and I had to really raid our savings and spend about $10,000 at that time to cover all of the costs of doing a round of embryo freezing. So for me, I'm 20 years out of my diagnosis, and I have healthy twin daughters, and they were born as a result of that fortunate information that was shared with me in time. So as a result of that experience, it really redirected my entire professional life, and I was working as a trademark attorney, very exciting. But for the past about 15 years, I have been working in this space, and I want to let you all know that I have met hundreds of young cancer patients, young adult patients that Dr. Zucker told you about. I've met their families, I've met their spouses, and I've heard, just how important this issue is to them. So years ago, this was really not an option for patients. Choices were very limited, especially for women. So there was really no discussion at all about insurance coverage. But as Dr. Zucker told you, this technology has really become standard, and these techniques, especially in the past decade, I would say, for egg freezing for women, have really become accepted, efficacious technologies that do provide a solution for patients if they are lucky enough to be able to afford it. Unfortunately, however, insurers have not kept up with the standard of care, and they have continued to label fertility preservation as a type of infertility treatment like IVF, and continue to label it something that is elective and therefore excluded. But the loss of, fertility and parenthood for a patient, I just want you to think about as not just a medical complication, but it's really affecting parenthood and reproduction, which are fundamental life functions and deserve the highest levels of protection, especially for young, vulnerable patients. But at a minimum, I would ask that you think about this as a side effect of treatment. And, typically side effects such as anti-nausea, medications, and even breast reconstruction, are covered by insurance. Hello?
Thank you. Hi, yes, ma'am. Thank you for your testimony. We will need you to start wrapping it up so that we can move on to the next caller. We have members that we lose to another committee for.
Sure, absolutely. Anyway, as Lindsay told you, there are 10 states that have passed this coverage, and the Veterans Health Administration, and most recently the Federal Employees Health Benefits Program is adding this benefit. So this has really been the trend over the past 3 years, and we're happy to share with you any information, as she said, about the costs, which are really pennies per member per month when spread across the whole population of insureds, and really take that burden from the individual patients who, may or may not be able to afford this. So I respectfully would just ask that you consider what we've discussed here today and pass this measure. Thank you for your time.
Yes, and thank you so much for your testimony. Broadcasting, next caller, please.
Caller with the last 3 digits of 919. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Hello, can you hear me?
Yes, we can.
Wonderful. Thank you, Madam Chair. For the record, my name is Amanda Klein, AMANDAKLEIN, and I am the founder of Nevada Fertility Advocates, which is a coalition of organizations dedicated to infertility and cancer patients in Nevada. I'm also co-chair of the Nevada Leadership Board for the American Cancer Society and was Mrs. Nevada 2020. Like Kendall, my mother was diagnosed with breast cancer during her reproductive years. My husband and I are also among the 1 in 6 couples who struggle with the disease of infertility. After many years of medical intervention and every member of my family contributing financially, Mark and I were able to welcome our beautiful daughter Emma into the world last year. But knowing firsthand the mental, physical, and financial and emotional toll that infertility takes on families, I cannot imagine starting this journey with a cancer diagnosis. AB 274 is a bipartisan bill that would support both men and women in the state of Nevada, and I am honored to testify in support of this bill. Thank you for your time and consideration, Madam Chair.
Thank you, Ms. Klein, for your testimony. Broadcasting, next caller, please.
If you recently joined the call and would like to testify in support of AB 274, please press star 9 now to take your place in the queue. Caller with the last 3 digits of 670, please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Good afternoon, Chair Harwigi and members of the committee. For the record, my name is Carrie Harrington. That is C-A-R-I. Last name is H-E-R-I-N-G-T-O-N. I'm the Executive Director for Nevada Cancer Coalition. As you heard already from Ms. Knox, Ms. Sabino, and Dr. Zucker, for those affected by cancer, fertility preservation must be made available and accessible to both our men and women. It can mean the world to those of us surviving what is already a most difficult and very costly life circumstance, and it positively affects quality of life for after treatment. As such, Nevada Cancer Coalition and our partners wholeheartedly support AB 274. We thank Assemblywoman Gorlow, Ms. Knox, and Ms. Servino for bringing this bill forward. Thank you.
Thank you so much, Ms. Harrington, for your testimony. Broadcasting, next caller, please.
Caller with the last 3 digits of 318, please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Hi, my name is Dr. Carrie Bedient, C-A-R-R-I-E. Last name is B as in boy, E, D as in dog, I-E, N as in Nancy, T as in Tom. Thank you very much for giving me an opportunity to support such an important piece of legislation for my patients and their families. I'm a reproductive endocrinologist at the Fertility Center of Las Vegas, a clinical assistant professor at UNLV College of Medicine and OBGYN residency, the director of reproductive endocrinology for the Mountain View OBGYN residency, and co-founder of Fertility Docs Uncensored. I'll be as concise as possible regarding my professional experiences with this. When I meet with patients who have a fresh cancer diagnosis, the hurdles in front of them are immense. They're dealing with a devastating, life-threatening diagnosis that has both physical and a very intense financial set of demands for tests and appointments needed to start their life-saving treatment that will ultimately destroy their potential to build their own biological family. They typically have 2 to 3 weeks between their cancer diagnosis and the start of their treatment to accomplish both cancer testing and fertility preservation. Those appointments are 2 to 3 times longer than average, and the tears at them are very real and very profuse. Despite a willingness from the fertility clinic to drop everything to fit in a patient with a new diagnosis of cancer and help them get the treatment they need, the patients frequently cannot financially access those services due to a complete lack of coverage. My office spends inordinate amounts of time trying to gain authorization from insurance companies for these patients. Many companies will deny coverage because these patients aren't currently infertile, despite the fact that their life-saving cancer treatment is all but guaranteed to make them infertile. Retroactive coverage is unheard of. We cut fees as much as possible to cover just required expenses. Cancer patients don't have time or resources to petition their insurance company for important treatment. This is unacceptable as a fertility doctor, and even more importantly, unacceptable for many patients who refuse or truncate their treatment in an attempt to save their chance of having their own baby. I can't tell you the anguish of telling a patient that you can help them and then watching despair wash over them because they can't afford the treatment now to help build their family later. Those tears cannot be fixed by any platitude. The effect is real and rapid. This bill will improve access to coverage for medically necessary fertility preservation and will give patients not only their life, but their biological family as well. I spoke yesterday with a 26-year-old man who I froze sperm for 4 years ago while he was acutely hospitalized with testicular cancer. After a tremendous effort from him, his family, his girlfriend, and our office, because of those really extraordinary actions for something that is relatively simple, we were able to get enough sperm to help him conceive. And now after 3 years of remission, he and his girlfriend are now going to start working hard as they plan to build their family. That should be available for all of these young patients who have had purely rotten medical luck through no fault of their own. Thank you for your time. And on behalf of my patients, please support coverage of medically necessary fertility preservation.
Thank you for your testimony, Dr. Bedian. Broadcasting, next caller, please.
Caller with the last three digits of 100. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Thank you, Madam Chair, Vice Chair, and Committee. My name is Connie Monk. That is ConnieMunk, and I'm the former Assemblywoman for Assembly District 4. I support AB 274 because it's imperative that standard health plans have coverage for persons going through any type of medical procedure, such as chemotherapy, that could cause infertility. As a breast cancer survivor myself, I know the devastating effects that chemotherapy has on the body. I urge this committee to support and pass 274 so that patients who want to preserve their eggs and sperm can be assured of fertility preservation through their insurance plans, and I thank you for your time.
Thank you so much for your testimony, Ms. Monk. It's so nice to have you with us in the Assembly again. Thank you. Broadcasting, next caller, please.
Chair, there are no more callers in support at this time.
Thank you. Next, we will hear testimony in opposition. Can we check the telephone lines, please?
Yes, Chair. To testify in opposition of AB 274, please press star 9 now to take your place in the queue. Caller with the last three digits of 229, please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Good afternoon, Chair and Committee. My name is Jamie Rodriguez. That's spelled JamieRodriguez. I'm the Government Affairs Manager for Washoe County. I am here in opposition of the bill, not on the policy behind it, but really on the fiscal impact to it. And I know that we received a fiscal note request, but it is not yet posted on Nellis, and so I wanted to address that we do have some concerns regarding the costs surrounding this. Very much appreciate the Assemblywoman and their proposed amendment, which takes out the self-funded or allows for self-funded insurance plans to opt out. However, that does only cover a portion of our insurance plans, and we do have some that are not self-funded. And as a rule, Washoe County has always tried to create parity amongst our insurance plans. So allowing that service for some of our employees and those who have insurance under the county and not others would create some strong conflicts for us, and then determining how to really fund that. So again, not here in opposition to the policy behind it, but some concerns about how we would be able to fund that. So just wanted to get that on the record, and thank you for your time.
Thank you so much for your testimony, Ms. Rodriguez. Broadcasting, next caller, please.
If you recently joined the call and would like to testify in opposition of AB 274, please press star 9 now to take your place in the queue. Caller with the last three digits of 561, please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Thank you, Madam Chair. For the record, Trey Abney, TrayAbney, here today representing America's Health Insurance Plans, or AHIP. Certainly have the same concerns as Ms. Rodriguez, so I'll be brief. We're always concerned about the expansiveness of a bill like this, and we try to be a constant reminder that increasing mandates increase costs on every policyholder. And of course, our position has nothing to do with the specific issues or policy we're talking about here, but the idea that, again, mandates increase costs. But despite all that, in the interest of time, I want to thank my good buddy, Ms. Knox, for proactively reaching out to us on this bill. It is always a pleasure to work with her on any issue, and we look forward to further conversation. So thank you, Madam Chair, for your time.
Thank you, Mr. Abney, for your testimony. Broadcasting, next caller, please.
Caller with the last three digits of 523, please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Thank you, Madam Chair, members of the committee. My name is Tom Clark. That's TOMCLARK. I'm here on behalf of the Nevada Association of Health Plans, and excuse me, I don't want to take up a tremendous amount of time this afternoon in opposition to the AB 274, and we have met with Ms. Knox and appreciate her willingness to work with us. But as has been said, the mandates that are in this particular piece of legislation, provide policy that has no guardrails, and that's going to lead to an increased cost of health care here in our state. We have a lot more questions than we've gotten answers so far, and I think it's important for us to put on the record that this bill's approach creates mandates that are static and incapable of reflecting changes that occur over time in medical technology and practice, and potentially leading to a lower quality of care for others, overutilization, and as Mr. Abney said, just higher costs and premiums across the board. So thank you, Madam Chair, for allowing me to speak this afternoon.
Thank you so much, Mr. Clark, for your testimony. Broadcasting, next caller, please.
Chair, there are no more callers in opposition at this time.
Okay, thank you. Let's move into testimony in the neutral position. Can we check the telephone line?
Yes, Chair, to testify in neutral on AB 274, please press star 9 now to take your place in the queue. Caller with the last three digits of 139, please slowly state and spell your name for the record. You will have 2 minutes and may begin.
For the record, Laura Rich, Laurarich, Executive Officer of the Public Employees Benefits Program. I'm testifying today in the neutral position as the PEB board has not had an opportunity to discuss this bill or take a position on it. PEB anticipates a very small fiscal impact to the program. The impact comes from mandated coverage for services that are not covered by the PEB self-funded plans today. PEB did perform an analysis on the use of these types of services and determined that there's a relatively low utilization rate among members participating in PEB today. Should that utilization rate continue, we believe the impact will be approximately $35,000 a year, so relatively insignificant in the grand scheme of things. However, there's some thought that the utilization rate may increase with the added coverage levels and also increased awareness, and that could affect future utilization and costs. I did hear Ms. Knox mention a possible amendment allowing self-funded plans to opt in, which would be very much appreciated, as this would provide the PEB board the opportunity to address this for those state and non-state members that participate in the PEB program. Thank you very much.
Thank you for your testimony. Broadcasting, do we have anyone else on the line in the neutral position?
Chair, there are no more callers in neutral at this time.
Thank you. Assemblymember Gorlow, would you like to give any closing remarks?
Yes, thank you, Chair Hadeghi. I would like to take a moment and express my gratitude to Lindsay Knox, Kendall Sabino, and Dr. Zucker for presenting with me today, and all those who called in for support of AB 274. I also would like to take a moment and thank former Assemblywoman Connie Monk, who originally had requested this legislation, and she asked me to carry it. I also want to thank all those who called in opposition. This is part of the process, and we look forward to continuing to work with all of the stakeholders. And I'd like to thank you again, Chair Howdy, and the committee for your time, and we will keep you all updated on our progress.
Thank you, Assemblywoman Gorlow, Ms. Lindsay Knox, Dr. Zucker, and especially Ms. Servino for sharing her story with us today on this very important issue. Thank you. I will now close the hearing on Assembly Bill 274. Members, the last item on our agenda is public comment. While we give those listening over the internet the opportunity to call in under public comment, I'm going to read some quick housekeeping remarks. I would like to remind those present or listening over the internet that the period for public comment is an opportunity to discuss general matters that fall under the purview of this committee. The public has already been given time to support or oppose specific legislation. We open and close hearings on bills so that we establish a public record of testimony. Therefore, public comment is not intended to continue a bill hearing. I would like to remind you that we limit public comment to 2 minutes. Please address your remarks to issues that fall within the jurisdiction of Commerce and Labor. If you direct your remarks to issues over which this committee has no oversight, I will ask you to redirect your remarks or terminate them. You may always submit written remarks for inclusion in the meeting record. With that, broadcasting, is there anyone on the line wishing to give public comment?
To take your place in public comment, please press star 9 now to join the queue. Caller with the last 3 digits of 490. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Hello, my name is Cyrus Hojani. The reason I called is because I hear a lot of people complain about healthcare and costs and everything, and we need to start addressing the reason why our healthcare costs are so high. The fact that ever since we had the repeal of the 1973 HMO Act, healthcare costs skyrocketed. We need to start addressing the root cause of why it's going up, about solutions. The Affordable Care Act has not overall reduced health insurance premiums. When you look at other countries, every industrialized country guarantees health care. So perhaps this is something that we can look into, or we can repeal the 73 Act. That's certainly a step forward because health care costs are eating up our budgets. It's even having a significant impact on our tourism community. Our country is very divided, increasing numbers of inequality, lots of polarization, dirty amounts of campaign contributions. The people are not being represented. And here in the state of Nevada, what we have is a casino fascist government where they control the unions like culinary and other interests like real estate have incredible control. We need serious campaign finance reform, or an idea, given the division, is to break up the country. That is why right now I am here passing flyers in the Asian district. I know there's a lot of concerns. There's a lot of tension, and I'm giving out flyers to consider breaking up the United States. So people who have differences can live in separate societies, and we reduce the tension, and perhaps we need a divorce. And I'm also hearing a lot of people, not just on the right, but even progressives, are not even happy with the current administration, and they weren't even happy before. All this stimulus, much of the money, regardless of which party, we're giving it.
Purview, it's a state government, not federal. Like your government have to thank you so much for your testimony. We can limit testimony to 2 minutes. So broadcasting, can we go to the next caller, please?
Chair, there are no more callers in public comment.
Thank you so much, broadcasting, and thank you, committee members, for sticking it out. I know this was a long day for us in Commerce and Labor. You should be getting the agenda for Friday's meeting shortly. Please, I would note, again, just take a look at the start time. We were going to be agendizing for noon or upon the adjournment of floor. So thank you so much. That concludes our meeting for today. We are adjourned. Thank you.
Thank you, Chair.